Sorry? I don't know. I just do the technical part of the presentation. So
So we all come here.
Wonderful, Constantine. Thanks. Yes, I can take it by my camera. Okay, please do that.
Sorry. Good afternoon, distinguished guests, ladies, gentlemen, and all the delegates that come to the 16th World Conference on Tobacco Health. A very warm welcome to you to the Tri-Plenary on Tobacco Taxation. During this plenary, we are aiming to highlight the challenges that countries face when raising the tobacco tax for the revenue and public health, and then how they have overcome these challenges. I'm pleased that our colleagues from the Ministry of Finance have joined us for this session, and I will look forward to hearing from them on the experiences of how they have overcome these challenges and made things happen. I would like to hand over to my colleague, Mr. Patricio Marquez, who is a World Bank lead health specialist and currently serving as Public Health Focal Point 1 at the Health, Nutrition and Population Global Practice of the World Bank.
Good afternoon, colleagues. It's a pleasure to be here, and I welcome all of you, especially right after lunchtime. So I think that we have a good audience for a very good session. As I said, as my colleague indicated, my name is Patricio Marquez. I work for the World Bank. And just before I proceed and introduce the speakers, let me state very clearly the World Bank position. The World Bank, since the latter part of the 1990s, adopted a critical decision. We do not finance or we don't support any investments that are related to the tobacco industry, either in the form of cultivation of the tobacco leaf or the commercialization of the product. However, what we do is that we provide a lot of resources to support the enactment of policies and measures to confront the tobacco addiction. Particularly, we are supporting measures to increase taxes that lead to price increases with the overall objective of making tobacco products unaffordable, and that should be the goal. So, having said that, I would like to reiterate also our commitment to work in support of the countries and in close partnership with our friends and colleagues from the World Health Organization, other regional organizations, as well as the International Monetary Fund, that are starting to come into the picture to support tax administration in some of the countries that we are getting involved. So this is a concerted effort in support of the countries. So having said that, let's begin with the presentation. By the way, colleagues in the podium, I'm going to be very strict, so in that way we can give time for questions and answers and a good discussion. So you will have 10 minutes, and the first person that is going to be speaking is Mr. Mark Goodchild from the World Health Organization, and he's an economist and is part of the tobacco taxation unit at WHO Geneva. So Mark, you have exactly 10 minutes to make your presentation, and then you will follow by our colleague Tibor, who will complement the presentation. Go ahead, Mark.
Thank you very much, Chair. Honoured guests, colleagues, friends, ladies and gentlemen, thank you very much for attending this session. I want to begin by saying I plan to keep my remarks very short to give more time to my colleagues on the table. The WHO Tobacco Control Economics team has worked now with over 70 countries on tobacco taxation and administration. And through this work, we've built up a knowledge base about the kinds of challenges they face. When we first worked with the ministries, we found that they often lack the data or the market knowledge or the analytical capacity to properly raise tobacco taxes. In fact, this is not surprising because in the past, tobacco taxation has not been a really big ticket item like VAT reform or tariff reform is for the revenue authorities. So our focus in the past 5-6 years has to be work with those ministries of finance and to build those technical and analytical capacities. Also, we've found that there is a problem of high staff turnover leading to institutional memory loss, and we've tried to address that by introducing tobacco tax policy cells or administration cells within the ministries of finance. And of course, there's the ever-present challenge of gaining high-level political support for raising tobacco taxes. This is especially the case when we're talking about sharp tobacco tax increases that will have the effect of reducing revenue, reducing consumption for tobacco control. So this gap that we identified was seen in ministries of finance has often been filled by the industry itself. So often the tobacco industry has become a technical advisor to the governments. And here you see what I call the industry playbook of advice that they give to the ministries of finance. And many of you will be familiar with these arguments. I just want to raise your attention to a couple of them, one of them being the Laffer curve argument. This is the concept that there are diminishing returns to raising tobacco taxes. In other words, the level of revenue will level off and maybe fall as you raise tobacco taxes. We haven't seen this really anywhere in the world. Maybe it's possible in high-income countries that already have high prices and high taxes. Maybe that's the case. But it's the industry arguing this in low and middle-income countries. So actually, this is a veiled attempt by the industry to critique the Article 6 guidelines, the recommendation that countries should achieve 70% of excise taxation. And also a new emerging threat that I want to raise is that of the tobacco industry uniting at the regional level to advocate for low tobacco taxes amongst customers unions and regional economic blocs. This creates a greater hurdle for us in terms of building consensus among countries to raise tobacco taxation. My final slide, I just wanted to address some opportunities from the tobacco community, the tobacco control perspective. And for us, the new WFCTC guidelines in Article 6 on raising taxes and prices is really an excellent resource for countries to use as a roadmap to raise tobacco taxes. We also know from our work with other countries that it is better for many ministries of finance to learn and hear from the success stories of their peers, other ministries of finance. They'd rather hear. It's more meaningful from them than it is from the tobacco control community. We've also seen a major opportunity is to leverage off country needs to finance their flagship programs. So for example, universal healthcare, NCD control is coming up, and they need revenue to fund those programs. Of course, the win-win argument is that this improves public health through reducing tobacco consumption also. At the same time, we still see countries, many countries, that are in economic crisis, whether that's because of a decline in the economy or a devaluation in the currency, creating debt financing needs. So I think today it's ever important to highlight the needs or the opportunities of tobacco taxation for raising domestic finance. And I had promised to keep my remarks short, to give each other time, and I hope that I've achieved that. Thank you.
Well, many thanks, Mark, for providing a general overview of WHO's experience and what you have learned. Now, in order to complement that presentation, I would like to invite Dr. You have to allow me for if I mispronounce your name, Dr. Tibor Szilágyi. Yes, Dr. Szilágyi is a native from Hungary. He's a medical doctor, and he has several postgraduate degrees. I'm not going to enumerate them, but the important thing is that in spite of his medical training, he has decided to cross the field in order to work on tobacco taxation issues. So he has been working as part of the Secretariat since 2007, providing support to the countries in implementing the guidelines for the Framework Convention on Tobacco Control. So his presentation is going to be focusing on guidelines for the implementation of Article 6 of the Framework Convention for Tobacco Control. Again, you have 10 minutes. Thanks.
Thank you, Chair. Maybe I can have 1-2 minutes more since Mark was too short. Was very kind about that. Thank you very much, Chair. And that's true. I started working as a tobacco control advocate in my home country in Hungary for a World Bank-funded tobacco control project. And the World Bank at that time was very active in Hungary in funding projects in the public health area and also in the area of health systems. And in fact, what we have started at that time, they started to bear fruit a couple of years later, and Hungary is now in the forefront of tobacco control in Europe. But now I'm representing the Secretariat of the Framework Convention on Tobacco Control. The Framework Convention on Tobacco Control is the first public health treaty which has been adopted by the World Health Assembly in 2003 and entered into force in 2005 and currently has 180 member states or parties which have already ratified it and committed to its full implementation. And it was just 3 weeks ago that the Framework Convention on Tobacco Control celebrated its 10th anniversary since its entry into force. So we are now entering our teenage ages, and which may not be easier than previously. So teenagership comes with new challenges, but also new opportunities for the treaty. And the treaty has a governing body, which is called Conference of the Parties, where all the parties to the convention come together every second year and take very important decisions concerning treaty implementation by its parties. And the last conference of the parties has taken place in the Russian Federation in October last year. And as a landmark decision, the Conference of the Parties adopted guidelines for implementation of Article 6 of the Convention, which refers to tax and price measures to reduce demand for tobacco. What are the guidelines adopted by the Conference of the Parties? They are consensus documents which are developed by groups of parties which provide assistance and guidance to parties on how to go about implementing the specific provision, the Article 6 of the Framework Convention on Tobacco Control. So let me start by saying that the Article 6 of the Convention already recognizes the fact that price and tax measures are effective and important means of reducing tobacco consumption, and calls upon all parties to introduce and implement price and tax measures, and so as to these measures to contribute to the health objectives. What does that mean? If we raise taxes that very likely result in price increases. Price increases will result in decreased consumption, and decreased consumption of tobacco products will result in better health for the population. So this is a key recognition which is already laid down in Article 6 of the Convention. But then the Conference of the Parties at its third session in 2008 has decided that it is not enough what we have in the treaty, because parties may need more advice and guidance on how to implement tax measures so that they can contribute to the health objectives of that country. So the third session of the Conference of the Parties requested the Convention Secretariat to provide a background paper on tobacco taxation, and as a result of discussing that background paper in 2010, the Conference of the Parties established a working group to develop guidelines for implementation of Article 6. The fifth session of the Conference of the Parties in 2012 adopted part of the draft guidelines which were developed by the working group, namely the guiding principles and recommendations, and also required the working group to continue its work and to develop and finalize the final text of the guidelines to be submitted for the next session, to the 2014 session of the Conference of the Parties. So a process was taking place between 2012 and 2014, where an open-ended working group continued to work on the draft guidelines and proposed a final text for adoption to the sixth session of the Conference of the Parties in October 2014. And at this session, with no objection from any of the parties, with great consensus, the guidelines for Article 6 were adopted on the 15th of October 2014. Sorry, it's not 2015, it's 14. So now we have the guidelines at our disposal, and I would like to introduce you a few elements of these guidelines. But before that, let me mention, and you already know that the tobacco industry is strictly opposing all measures which were found to be effective in tobacco control. So that was not different with the taxation Article 6 guidelines. So that the tobacco industry and one of its front group, how we call it, the International Tax and Investment Center, which has a board of directors that includes executives from Philip Morris International, BAT, JTI, and Imperial Tobacco. So they organized a briefing session for the parties to the convention right before the sixth session, the opening of the sixth session of the Conference of the Parties in Moscow, just to brief the delegations and mostly the ministries of finance and trade representatives that were delegated to attend the sixth session of the Conference of the Parties by the different parties, about the need to have a balanced approach to tobacco taxation, not to require measures which will result in huge increases in illicit trade in tobacco products, and to require measures which parties will not be able to implement afterwards. And as a response to that invitation, which was sent by ITIC to all parties to the convention, the convention secretariat also stand firm, and we also wrote a letter to all parties to the convention saying that this is not a meeting which is related how to the sixth session of the Conference of the Parties. It's not a meeting to which the Convention Secretariat can sign up to or organized by the Secretariat. And in fact, we isolated ourselves from this initiative of ITIC, which we consider a tobacco industry front group. So the Convention Secretariat has informed parties and called upon parties to go ahead with the discussion of the draft guidelines as they were submitted by the working group established by the COP. And here on this slide, you will see the guiding principles of the Article 6 guidelines. And let me just highlight one or two of this list that, again, effective tobacco taxation and taxes significantly reduce tobacco consumption and prevalence, and at the same time are an important source of revenue for the governments. And tobacco taxes are economically efficient and reduce health inequalities. And the tax systems and tax administration, which are to be measured, applied by the parties, are efficient and effective if they follow the guidelines that were adopted by the Conference of the Parties. And again, these tobacco tax policies should be protected from vested interests of the tobacco industry. These are the areas covered by the guidelines, and I will not enter into details since colleagues from the different parties will provide examples on how these different areas can be addressed in a country in a way so that they can contribute to health objectives of the country. I will just go to my last slide, which is based on the latest official communication, implementation reports of the parties submitted to the Convention Secretariat in 2014. And let me thank the World Bank for assisting us in analyzing the information concerning taxation and prices from these implementation reports. And also let me thank to my colleague, my tobacco control advocate colleague Konstantin Krasovsky from Ukraine, who contributed to the analysis of this data, and we are very grateful to the World Bank and Konstantin for providing us this information. And just a few information for you to see the progress which the parties are making and have already made before the adoption of the guidelines in implementation of taxation measures. The trend of the proportion of reporting parties which have reported levying excise taxes have increased to 92%, up from 67% in 2010 and 85% of the reporting parties in 2012. And the combination of specific and ad valorem type of taxes, of excises, has become more prevalent than before. More than 2/3 of parties have increased their taxation rates since 2012, when the parties submitted their previous implementation report. And the average proportion of taxes in the retail price of the most sold tobacco product in the country has further increased to 67%, up from 57% in 2012. But, there is always a but, and what poses the challenge to be addressed for the years to come. There are still significant differences between the parties in regions in terms of levels of taxation and prices of tobacco products. And with the use of guidelines, we aim to close the gap between the different regions and sub-regions and ensure that tobacco taxes in all parties to the Convention are raised to a level which could contribute to the health objectives related to implementation of the FCTC. And these are just two pictures which are included in our 10th anniversary brochure. As I mentioned, we just turned 10 about 3 weeks ago. So thank you very much for this opportunity, and we'll hear country examples on how to successfully implement taxation measures as required by the Convention. Thank you.
Okay. Many thanks, Tibor. Colleagues, by now you have heard presentations by our colleagues from the World Health Organization that have provided the general framework for the discussions. We heard in the last presentation about the guidelines and how the guidelines that are rooted on evidence are helping shape the processes within the countries in order to enact the necessary fiscal reforms that will help implement Article 6 in each of them. So now moving from international organizations to countries where things happen, it's an honor for me to present Jeremiah Paul, who is the Undersecretary of the Department of Finance of the Republic of Philippines. And under the leadership of his president, he became the architect in designing and leading the implementation of the sin tax reform in that country. So Jeremias, please, the floor is yours.
Good afternoon to everyone. I hope, it's after lunch, so it's very difficult to stay awake, but I'm going to tell you a story of the Philippines where we essentially applied the FCTC Article 6 guidelines. My presentation will be, I'll give you a background, the wins of the sin tax reform, key success factors, and concluding remarks. Sin tax is essentially reforming excise tax taxation of alcohol and tobacco products. As a background, the Philippines is among the top smoking countries in Southeast Asia. It has one of the strongest tobacco lobbies with deep political and business connections. In fact, some studies have said that it's the strongest in Asia. Before we embarked on the reform, we had cigarette taxes and prices among the lowest in the world. And when we worked with our health advocates, they pointed to us that the estimated annual cost to the economy was 177 billion pesos versus what we were collecting then as 25 billion pesos. So for us, it was a no-brainer. If we collected 25 billion and the economic cost was 177, there should be a case for increasing taxes. And the Philippines ratified the FCTC in 2005. What was the rationale for reform? To help finance the universal health care program of the government, to address public health issues relating to alcohol and tobacco consumption, to simplify the current excise tax system on alcohol and tobacco products and fix long-standing structural weaknesses. We essentially address the architectural issues with regards to tobacco taxation. We remove the price brand classification freeze, we level the playing field, we reduce the number of tiers, We made the tax system more buoyant by indexing tax rates to inflation. What do I mean by this? If you see this, there's premium, high, medium, and local. These are our 4 tiers before. And because of the price classification freeze, those that were in tax in brands that were present in 1997 had essentially low tax rates compared to similarly priced products. So when we remove that price classification freeze, the low here, which was really taxed at 272, became tier 1, which is essentially 12. So for medium, became higher. So we essentially moved from a 4-tier to a 2-tiered system, and eventually to unitary. The argument is that this is a health measure, and there's no such thing as moderate smoking. Whether it's a cheap cigarette or an expensive cigarette, the harmful effects are the same. So Republic Act number 10351, it's an act restructuring excise tax on alcohol and tobacco products, was signed in December 19, 2012. It's a landmark legislation under the Aquino administration. It's fundamentally a good governance measure with positive impact on both public and fiscal health. And it has been guided by elements contained in Article 6 FCTC guidelines. To give you an idea where we went, we had to pass through, you have the Ways and House of Representatives, we go to Senate by CAM and the executive, the Office of the President. But this is where the tobacco industry controls the House Committee on Ways and Means in the House and the Senate Committee Ways and Means, because these are the ones that essentially tackles tax measures. Again, what were the issues raised? When we went to Congress and the Senate, raising tobacco taxes will reduce, not increase revenues. It will adversely affect tobacco farmers. It will increase smuggling and illicit trade. It will negatively impact the poor. It will increase unemployment. It will destroy the local tobacco industry. For you who are in the tobacco control business, don't these issues sound familiar? These are really from the tobacco playbook. So these are the same issues which are raised in other countries. So we essentially went through that process. If you notice, there's an axe in our head, an arrow, and a sword. We really were bruised, but we made it to the finish line. So it's a win for fiscal health. The decline of share of tobacco and excise taxation was reversed because this was not indexed to inflation. It went up dramatically. We also got investment grade because that was one of the key elements that we had to improve our revenue performance. And by doing that, we essentially reduced our borrowing cost, and it's essentially generating more fiscal space. We also increased our funding for the Department of Health. So you see this line, it's really going up. It's the 2015 budget is up 63.2% over 2013 levels. And it made possible the enrollment of the sponsored poor in our PhilHealth insurance from 5.2 million families in 2012 to 14.7 million principal members and their dependents, which really totals about 45 million, or roughly about 50% of the Philippine population. It's also a win for fiscal and public health, and one could say a win for tobacco control, because the removals, which is essentially represents consumption, dipped, while the revenues shot up like a jet. And it's a win for the poor because we were able to generate fiscal resources to essentially for the premiums for the poor. You see this? And according to the smoking prevalence study of Dr. Antonio Dance, based on the National Nutrition Health Survey in 2013, the prevalence of smoking among adult Filipinos went down from 31% in 2008 to 25.4%. According to him, the the past 3 decades, it was never below 30%. It was only in 2013 it became below that. And there are 3.2 million less smokers in the country because of the sin tax law, and approximately 32,000 deaths were averted. I think we are one of the few finance ministries that not only thinks of revenues, but also about how many lives are saved by not smoking. What are the key success factors in this campaign? Focus on health, political support at the highest levels, constructive engagement with stakeholders, just-in-time analytical support, strategic communications, and effective use of strategy and tactics. It's really important to frame reforms in terms of health because, one, there is broad-based political support for universal health care, and politicians do not want to be seen as being against health because in the Philippine context, if they're sick, they go to their, poor people are sick, they go to their politicians for help. And during the debate, when we're doing about technical things, at the end of the day, we say, Mr. Chairman, this is a health measure, so they stop arguing with us. It's very important to have political support. We had unwavering support from our President, Aquino, unqualified support from the chairs of the Ways and Means in Congress, Congressman Sid Ungab and Senator Drilon. Congressman Ungab now is the chairman of the Appropriations Committee now, and Senator Drilon is now the Senate President. We also had support from the leadership of the League of Mayors and League of Governors because we showed to them that their constituents will have universal health care. And also, we had a whole of government approach because in a typical campaign, the positions of finance, health, budget, agriculture are different. We essentially got the cooperation among them, and we essentially sang to the same tune. We also had constructive engagement with stakeholders. It's really important to listen and to reach out, even to those farmers, to everybody that are against you. I remember talking to farmers who were demonstrating in front of our office and told them about the impact of the sin tax law, and there would be necessary safeguards for them. And health advocates were critical partners. We had what you call the White Army that essentially helped us. We had the civil society, and they essentially help us also. We had a dialogue with industry players and other affected stakeholders because we really wanted to listen to their concerns and come up with a win-win solution given the political landscape. And at the end of the day, we disclosed to them what was negotiable and non-negotiable, and we were really non-negotiable in terms of health. Because even the industry agrees with tax increases, but what was not negotiable for us is that there should be significant tax increase to have an impact on health. Those significant tax increase, Philip Morris described as disruptive. Just-in-time analytical support. It's also very important to have evidence-based research and scenario modeling. We did a lot of scenarios, what would be the price, what would be the tax, what would be the impact on deaths. I essentially gave the same assignment to the World Bank, the WHO, IMF, and academia, because at the end of the day, I cannot say this is what the World Bank says. It's you who will be presenting in Congress, and that you will be the one defending this measure. And I found very useful the knowledge portals in tobacco control available in the internet. I even read the legacy documents in the internet, which essentially was a result of the compromise agreement in the US. And there I learned that the elasticity for demand for tobacco is negative 0.5, where in the Philippines they were saying it was negative 0.8. So when it was discussed in Congress, I said, even your own internal documents say it's negative 0.5, so why do you say it's negative 0.8? We had a constant vetting of analytical results, but then at the end of the day, evidence-based analytical support is a necessary but not sufficient condition. It's really how you manage the political landscape, the political economy of reform. In conclusion, sin tax has generated substantial fiscal space for health. It is good for fiscal and public health. Note that I use substantial fiscal space instead of just revenues because fiscal space is a broader concept. Also, sin tax reform is not only a revenue and health measure, it is also more fundamentally a good governance measure. A good governance against the vested interests of the tobacco industry. That's why it was very important that political support at the highest levels was very key. And we adopted a whole-of-government approach and formed strategic alliances with stakeholders, including civil society. Again, even if you have sources of financing, it's also, while it is a necessary, it's not a sufficient condition for higher health expenditures. Efficiency, effectiveness, execution capacity are key to delivering universal health care services on the ground. Implementation challenges remain, so we have no room for complacency. There is a need for continued vigilance because the tobacco industry does not sleep. And in closing, a lot of you are health advocates. I'd like you to put yourselves in the minds of Finance Ministry officials because it's very important that you understand where they're coming from. Predictable revenues are very important to them. They're also being asked a lot of financing. You have financing demands from various sectors, education, health, infrastructure, etc. So we really need to balance all of these demands. That's why they're concerned that UHC, if not spent well, can be a bottomless pit. There's the need for cost effectiveness and efficiency measures, and to look at the value for money. And generally, Finance Ministry officials are against earmarking as they essentially prefer a one-fund concept which allows flexibility. But nonetheless, as shown in the Philippine experience, if the health ministers and the finance ministers work together with other agencies, it can be a win for health and a win for public health also. Thank you.
Well, I think that in spite of the early years of the reform process in the Philippines, it has all the ingredients to become a good international experience. But as Dr. Paul clearly indicated, it will require additional efforts to confront some of the ongoing challenges and to monitor the implementation of some of the elements that are part of the reform process. Moving from the Philippines now to another East Asia country that has had, I would say, a long experience in adopting several reforms to increase tobacco prices. I will turn to our colleague, Dr. Warotai Kasol Pisikul from Thailand. He's the Executive Director, Fiscal Policy Office, Tax Policy Bureau at the Ministry of Finance in Thailand. The good thing about our colleague, Dr. Waratoi, is that as Dr. Paul has done in the past, he was a colleague of ours at the World Bank. So, Dr. Waratoi, the floor is yours.
Well, thank you very much. First of all, I'd like to thank the WHO for inviting me to such a very important event. I was asked by Mark Goodchild to speak on Thailand experience on tobacco taxation. Well, let me begin with, giving you some background of tobacco and cigarette taxation in Thailand. This is done by one of my staff, a very colorful presentation. Actually, the tobacco and the cigarette is one of the excisable items under the excise taxation law in Thailand. We have 20 excisable items, and tobacco and cigarette is one of the 20 items. As for tobacco and cigarettes, the ad valorem and specific tax rate are applied. Whether which one is effective depends on the revenue generated by either the ad valorem or specific tax. If the ad valorem are used, the higher revenue, it will be applicable. So it depends on whichever use the higher revenues will be applicable. For the excise tax, the ad valorem tax at the moment it's 80%, as you can see from the slide. And the specific tax for cigarette, it's 1 baht per gram, or about 20 baht per pack of the cigarette. And if it comes from the imported goods, it would definitely be liable to the custom tariff. And the custom tariff rate, it's 0% for the ASEAN countries after the AFTA scheme. As for the non-AFTA, we apply 60% on the CIF of the imported cigarettes. The tax base for the cigarettes domestically produced actually is the manufactured, factory produced price. And apart from the excise, the 87% excise, we also impose the local government taxation as well. So this means the local taxation plays a role in the Thai context. Apart from local and central government taxation, we levy a so-called the earmarked tax, which is not a budgetary, it's off budgetary fund. At the moment, we have 2 kinds of funds under the earmarked taxation, which is the Thai Health Promotion Fund and the Thai Public Broadcast Services. So this is give you a general background of the excise taxation in Thailand. And moving along, I'd like to share with you an example of how the different kind of taxes are applied in Thailand. So, for example, this is one of the very popular brand, locally produced brand in Thailand. I would like to call it the Big K. Its initial brand is K, all right? And as you can see, the overall tax liabilities comprise about more than 50% of the retail prices. So I suppose we are not the lowest tax country in the world, so we tax it heavily. And this is an example. If the ex-factory price is about 32 baht, which is roughly $1, and the retail price is about $2, so the overall tax, whether central government and local government taxes, comprise about more than 50% of the retail prices. This is just the simple illustration of the excise revenue, the latest data from last year, last fiscal year actually. The overall, taxation on tax revenue on cigarettes and tobacco comprise about 16% of the excise revenue in Thailand. 61 billion baht, it's equivalent to about $2 billion a year. The number one revenue raiser of the excise tax is alcoholic beverage. then automobile and petroleum products. Then tobacco is the fourth, largest revenue raiser. This seems interesting to me. I'd like to, find the relationship between the excise rates, excise tax rates, the sales of cigarettes, and the revenue, the excise revenue. This is, we try to compile the data about 10 years back, and we have 3 times increased the tax rate. First occurred in 2007, then 2009, and 2012. Amazingly, not every year that we increase the taxes, the sales dropped. So some year like 2007, sales even went up, revenue went up. But for 2009, as you can see, when we increased from 80% to 85%, sales dropped slightly, revenue increased. Amazingly, even we increased from 85 to 87, which is the current tax rates, sales went up. And the latest figure showed that in the year 2014, even though the tax rate remained unchanged, sales dropped and revenue dropped. This is because of the social and political turmoil in Thailand in that year. So people didn't want to smoke, perhaps, or smoke less maybe. So there's no, clear relationship between, tax rates, revenues, and sales. So it depends on, situations. Number of smokers in Thailand, I would say it kept, reducing. Maybe, it would be a result of our effective tax policies, non-tax policy as well. So the average number of smokers per total of population is about 20%, dropped from 32%, in 1991. And I'm not trying to challenge, everyone, especially, trade economists, but this is a slide that I always, present in my graduate school classes to my, taxation policy classes, that there's always, an optimum point that tax rate will generate the maximum revenue. Beyond that point, if we keep increasing the tax rate, the revenue will decline eventually. So this is a so-called Laffer's curve, which is named after the Arthur Laffer, professor of economics. So many economists try to prove whether this theory is valid or whether it's can be applied to the real world. But I've been trying myself, but I couldn't come to the conclusion. But it's a caveat that it's not always that tax increase would result in revenue increase. It's to some certain point, if we keep increasing tax rate, substitution effects would outweigh the income effect, and the revenue will decline eventually. So this is a very brief touching on the illicit trade. I think the more detail will be given in the room across the hallway. And in Thailand, we try to estimate the number of illicit sales of the illegal cigarettes, but the number is not officially published. My point is that there's a huge difference between tax rate between Thailand and the neighboring countries. If these tax rate keep on, the tax gap keep on increasing, there will be a higher risk of illicit trades, and there's a incentive for illicit trade. And furthermore, in some countries, if I'm not mistaken, in some countries, a part of excise revenue is allocated for illicit trade control or combat illicit trade. But in Thailand, there's no exact specific budget allocated for part of the excise that is not allocated to the illicit trade combating. And I'd like to conclude my presentation by saying a few words that going forward, what are we going to do with the excise tax on tobacco and cigarettes? The current tobacco tax system in Thailand relies almost entirely on environmental tax computed from the operator's declared costs, be it domestic manufacturing costs or CAF for importers. This has, historically been a source of confusion and frustration both for business and government due to the difficulties in identifying and verifying products through costs. Sometimes the imported products, tend to undervalue the CAF. We have a accusation against one of the biggest manufacturing in the world, and the lawsuit is still going on because of the under-declared CAF price. At the same time, the advalorem system collectively widens the price differences between higher-priced brands and the relatively cheaper brands, which then induces adult consumers to trade down to lower-priced products, including roll your own, which is becoming more and more common in the Thai society. Such a tax system may not reduce overall consumption and therefore have the desired health benefit. In terms of tobacco tax structure, ideally, a single specific tax should be adopted as this effectively resolves the current issues arising from advalorem brands. Advalorem natures of the current tax and the tax differential between low-price and high-price brands. However, in moving directly to this system, it may be difficult to achieve an equitable balance for all parties, given that the tax differential between various cigarettes price categories within the Thai markets. And the Ministry of Finance recognized that issues as far as the limitation has begun the necessary legislative process to address these issues through two key changes. The new tax system which is under the proposal, the new system will levy, tax on cigarettes both by quantity and values. So it's going to be a mixed system from currently either one of the two, but in the future it's going to be the mixed system. By quantity component, will effectively prevent cigarette price to become too low, while the advalorem component will still be needed somewhat to maintain the market dynamics, but the tax base will be changed to a retail selling price instead of the manufacturing price. We're going to change the tax rate to the base for the advalorem to the retail selling price to enhance the transparencies. So probably this gives you a rough idea of what we have been doing, and going forward, what are we going to do. So I think I will stop here. Thank you.
Very good. Well, another great presentation by our colleague from Thailand. I think that we were able to learn some of the pitfalls, some of the challenges, but then again, some of the measures that have been adopted by the government of Thailand to move forward the agenda. One interesting aspect, I guess, that in spite of economic orthodoxy that tends to look with bad eyes earmarking, is that both in the case of the Philippines as well as in the case of Thailand, some of the revenues that have been collected from increases in the excise taxation on tobacco as well as alcohol are being used for specific purposes within the budget. One, in the case of the Philippines, to increase coverage under the Health Insurance Act, and in the case of Thailand, in order to promote, in order to finance the health promotion agency, one of the few agencies in the world that has that responsibility in pushing forward the health promotion agenda, and that's financed partly through the revenue collected from excise taxation. So those are interesting examples that sometimes economic orthodoxy needs to be adjusted if the social goals are clear. Now, the final presentation, moving from East Asia to Southern Africa. Again, we are going to be able to hear a very good case study of a long process that has been followed in South Africa in order to increase the excise taxation in that country. So we have another distinguished speaker, Professor Corny van Wolkley, who is a professor of economics at the University of Cape Town. And in the particular case of Professor Corny, I had the opportunity to work with him and learn from him in different countries where we have been able to establish partnerships, more recently in Ghana. So, Corny, the floor is yours.
Chairman, ladies and gentlemen, it is a real privilege for me to be here this afternoon. I've listened to some really wonderful presentations of other countries, and I am reminded of a song by Neil Diamond which goes more or less as follows: except for the names and a few other places, the story is about me. And to some extent, the story of Thailand and the story of the Philippines is very similar to the story of South Africa when it comes to the excise taxes on tobacco. I think tobacco control in South Africa has been a somewhat longer story in South Africa, and it all started in 1994. In 1994, we had the democratic transition from essentially a minority, white-ruled government to a democratic government. And during this period, a new government came into power with a completely new agenda. And the new agenda was driven by Nelson Mandela and by his cabinet. And one of the focus areas of the new government was that of primary health. The previous government was very much hand in glove with the tobacco industry. We find that the new government had no relationship with the tobacco industry, and rightfully so. And they said, we are going to push primary health. We don't want to have a situation where we're going to have to spend lots of money on curative medicine. We want to prevent people from getting sick. And one of the ways that the government went about doing this is to reduce tobacco use. And we had a particularly effective Minister of Health in our first democratic parliament. Her name is Nkosazana Dlamini Zuma. She's currently the chair of the African Union. And she pushed through legislation in parliament that would ban advertising, and it would also ensure clean indoor air policies. And this was eventually, after a big struggle against the tobacco industry, and to some extent also within the whole political arena, it was pushed through in 1999. It was eventually very well accepted. It was accepted well by the public, and it became effective in 2001. And what we see was that there has been a denormalization of tobacco use in South Africa. But I don't want to talk about the legislative aspect of the changes in South Africa. I want to talk about the excise taxes. And before I continue, South Africa received the Terry Awards for the best leadership shown by a government department in 2000, which was very well deserved within the context of the legislation that had been passed in 1999. So if we have a look at what happened to excise taxes in South Africa, if we take a really long-term look of what's happened over the past 45 years, what we've got over here is the excise taxes over a period of 45 years expressed in real terms. In other words, taking out the effect of inflation. And what we see that during the 1970s and the 1980s, there's been a very significant decrease in the real excise tax per pack of cigarettes. And this was very much a case of the tobacco industry advising the government, saying, if you were to increase the excise tax, you're going to have all kinds of dramatic things, and the government believed them. There was not a strong tobacco control movement in South Africa, and what we find is that because the excise tax was levied as a specific tax, the real value got depreciated very quickly because South Africa was experiencing inflation rates during that time period of between 10 and 20%. What we also see is that this resulted in similar trends in the retail price of cigarettes. From 1970 through to the early 1990s, we see that there was a 1/3 decrease in the real price of cigarettes, driven primarily by a decrease in the excise tax. However, in the early 1990s, as the new government came to power, what we're finding is that there's been a significant increase in the excise tax, but at the same time, this was leading to a proportional increase in the retail price of cigarettes. People don't respond to the excise tax, people respond to the retail price. So we see that an increase in the retail price of cigarettes was going to have the impact of reducing consumption. So let's look at this in a slightly different way. If one looks at the retail price of cigarettes, in South Africa we've got a fairly simple tax system. It is a specific tax, that we don't have an ad valorem component. We simply have a specific tax. If we remove the specific tax and the VAT component from the retail price, we end up with what we call the net of tax price. And if we have a look at what has happened with the net of tax price, we see that between 1970 and the early 1990s, the net of tax price was broadly constant. However, since the early 1990s, the net of tax price was increasing. This was the tobacco industry increasing the price, that component of the price that they control, quite significantly, faced with a situation of legislation and faced with increased excise taxes. So in a very perverse, weird type of way, we find that the tobacco industry was aiding the cause of tobacco control, even though it was not their intention. If we have a look at these red bars indicate what has happened to the excise tax over time. And what's happened with excise taxes over time is they decreased between 1970 and the early 1990s, as we've already talked about a moment ago. But then they increased very sharply and dramatically from the early 1990s onwards. What happened was the government had stated categorically in 1994, we want to put the total excise, or rather the total tax burden of cigarettes at 50%. So what happened since the early 1990s, there was an increase in the excise tax, and the government was increasing the excise tax quite sharply during that time period, both in nominal and in real terms. As a result of these increases, we find that there was an increase in the overall tax burden. However, after 1997, this 50% tax burden had been achieved. And what happened then was a very interesting and strange combination of the government would increase the excise tax, the retail price would increase, the industry wanting to maintain its profitability would increase the net of tax price, which would increase the retail price. Next year, the government would increase the excise tax again, and we find that we were going into the cycle between 1994 and 2010, where there was this very interesting dynamic between the increase in the excise tax and the increase in the net of tax price. In South Africa, like in many countries, we also have VAT, and the VAT components are indicated by those green bars over there. The important thing, though, is to understand that the increase in the retail price was triggered by the government, but it was maintained through the tax system that we had in South Africa and through the rules that were very clear right from the outset. It was maintained by the tobacco industry. This was not that the tobacco industry in South Africa was wanting to have some tobacco control agenda. It was purely driven by commercial interests, as we will show in a moment. So has this been successful? The numbers that have been shown for Thailand and the numbers for South Africa are very much the same. In the early 1990s, cigarette prevalence, smoking prevalence in South Africa was 33%. of all adults. In 2012, it was approximately 20%. There was a decrease from 33% prevalence to 20% prevalence within the space of 20 years. If we have a look at aggregate consumption, we see that it is very, very strongly negatively correlated with the real price of cigarettes. The red line over there indicates aggregate consumption, and we see that it is nearly perfectly correlated with the price increases that we have seen since the early 1990s. So from this perspective, we find that the tobacco control policy in South Africa has been particularly successful. This is just showing the side of the excise taxes. Of course, at the same time, there was also legislative interventions that made cigarettes less desirable and less socially desirable as what they were before the time. So let's have a look at excise tax revenue and industry revenue. This was again one of the points that was raised often during the 1970s and the 80s, where the tobacco industry was advising the government saying, please don't increase the excise tax, because if you do, you might actually get less money. That was, of course, completely self-serving and false. And what we see on this diagram over here is the relationship between the excise tax per pack, which I indicate on the secondary axis, and the total amount of revenues that was obtained by the government. And what we see is a very clear positive relationship in this particular instance. As the excise tax per pack decreases, so one tends to find that total revenue would decrease, and similarly, if the excise tax increases, there was an increase in the excise tax. Because of this rather strange mechanism that the tobacco industry followed, especially from the early 1990s onwards, of increasing the net of tax price, one would ask, well, was that clever from the perspective of the tobacco industry? And let's have a look what the implication of that was. The red line indicates total industry revenue. This is not necessarily profitability, but it would probably closely follow the industry's profitability. It's the total turnover that they have received over this time period, and we see that despite the fact that since the early 1990s there's been a very dramatic decline in consumption, we see that between that period and 2010 there has been a very consistent increase in total revenue by the industry, suggesting that the industry has become more profitable over that period, and it has. However, since 2010, we see that there's been a decrease in industry revenue, and essentially what has happened is the industry has run into a price war with other operators in the South African cigarette market. It became so profitable that other operators came into the market, and at the moment we see that different prices, or rather the different brands of cigarettes, are being discounted. An issue that has been talked about a lot, and that I want to spend just a minute or so talking about, is the issue of cigarette affordability. Cigarette affordability considers both the price and income. And just at the previous session when we talked about the launch of the Tobacco Atlas, one of the speakers made a specific comment about cigarette affordability in the Middle Eastern countries being a real problem, in that the price of cigarettes is very low relative to people's average incomes. So cigarette affordability considers how much money one requires to produce, to consume cigarettes. And the amount of money is typically expressed as a percentage of the GDP. So the affordability concept that we have used over here is how much or what percentage of per capita GDP do I require to purchase 100 packs of cigarettes? Why 100 packs of cigarettes? Simply because it's a nice number. It doesn't mean anything in itself. But what we can then do is to look at what has happened to the affordability concept over time. A decrease in affordability means that we are using less resources, it's becoming cheaper, in order to consume 100 packs of cigarettes, as opposed to an increase in the affordability concept, which means that it's becoming more expensive and it requires more resources to be able to afford those a pack of cigarettes. And again, what we see, this closely follows the price of cigarettes. During the 1970s and the 80s, cigarettes became more affordable. Especially during the 1990s, we find that cigarettes became less affordable. From the period of 2000 onwards, even though cigarettes became more expensive, they were becoming somewhat more or less affordable, primarily because there was a big increase in GDP growth in many of those years. If we compare that to per capita consumption of cigarettes, we see again a very, very strong negative relationship. Again showing if something becomes less affordable, people are going to consume less of it. If it becomes more affordable, people are going to consume more of it. So the lessons that we've learned are as follows. The demand for cigarette is determined by both the price of cigarettes and by average incomes. And importantly, and this is a general comment, we find that in order to ensure that cigarettes do not become more affordable, the government has to regularly adjust the excise tax on cigarettes, taking both inflation and economic growth into account. I want to finish my presentation by briefly talking about illicit trade in South Africa. Illicit trade is something that the tobacco industry is hammering on in South Africa, as in most other countries. It is exaggerated. It doesn't mean to say that it does not exist, but it is hugely exaggerated by the tobacco industry. In South Africa, we do not have the smoking gun to show that the tobacco industry has, or the established tobacco industry has been involved in illicit trade. But there's been numerous instances around the world that indicate that there's been a strong tobacco industry influence in illicit trade. In the Tobacco Atlas, I drew this slide, and basically what it shows is that the Tobacco Institute of Southern Africa, a tobacco industry front group, has since 2006 been hammering on the idea that 20% of the South African market is illicit. It's been doing that for a very long time period. However, and I indicate that in the red block, we see that in 2012, suddenly they change around and they say, no, sorry, we got the numbers wrong in 2008. It was only 8% in 2008, but it had increased so dramatically. However, in 2008, they were telling us that 20% of the market was illicit. The point that we are making is, if the industry in 2008 was lying, and obviously lying, how do we know that they are telling the truth at the moment? There is no credibility in the tobacco industry's claims about illicit trade. That does not mean to say that illicit trade does not exist. It does. But what it does mean is that if the government wants to take tobacco control seriously, it should not, in the first place, listen to what the tobacco industry has to say about this matter, but rather what do independent sources say, and what's happening with statistics that have been verified from a number of different sources. So, the take-home messages are the following. In the case of South Africa, as is the case with all other countries, political will is crucial. Without political will, you will get nowhere. In the case of South Africa, as in many other countries as well, the structure of the excise tax is crucial. Countries that have got weak excise tax systems tend to not be able to use the excise tax system as a public health tool. A simpler system is typically better than a more complicated system. A specific tax is often better than an ad valorem tax. At the same time, what we saw in South Africa very clearly, and what we see in countries around the world, is that an increase in the excise tax will reduce consumption, and it will increase government revenue. And the last thing that I want to just mention is, do not believe the tobacco industry's claims about illicit trade. They are self-serving and in 10 to 1 not true. Thank you.
Well, colleagues, we have heard very good presentations, and actually some of them offer a lot of good examples to other countries that are embarking in this type of processes. So the floor is yours now. I would like to open the floor, and I will invite 5 questions before I ask our colleagues to respond. So, who wants to be the first one? Okay, could you line up? Could you line up, please? Okay, we have the first three.
Yes, you see, what I see from all three presentations from the countries, they all provided graphs of annual revenues. And for each of three countries, for the very last year, revenue is declining. It looks like that Laffer curve is true, and they probably reach the highest point of excise tax, and maybe they could not increase it anymore. And as to Arthur Laffer, I can say that last year he published a book on tobacco taxation. You can download it, it's available online, you can download it for free. But when you download it, you see the chapters are labeled, all files are labeled as PMI taxation book. PMI means Philip Morris International taxation book. This book was commissioned by Philip Morris. And actually, what I see from these examples, that in every country, the decline of revenue was done because the tax is too low. In Philippines, they increased taxes very high in the 1 year, and then it was stable. So next year, yes, you have decline in revenue because one of the effect of taxation, it's decrease in smoking initiation. So it means that next year, smokers who die were not fully replaced by young smokers, but next generations. And all other tobacco control policy also have long-term effects and for other countries. So what I see, it's, for example, from my country, Ukraine. So when we increase taxes every year, we have increase on revenue every year. When we stop increased taxation, we see decline in tax revenues. So I see it's in South Africa, your revenue is only 50%, as I understand, to the final price. In Thailand, it looks like 87%, well above the limit, but actual, in final price, the revenue is only 52%, if I'm correct. Yes, and also in Philippines, you see, you have planned to increase it more. So the questions for all three countries, are you going for the next increase of your tax rate to increase your revenue and continue decline of smoking consumption? Because as I see, you actually stop this process and you at least see the decline in revenue.
Thanks, Konstantin. Next question.
I'm Nisu Maung, Dean of the University of Public Health from Myanmar. Okay. Thank you very much for your very informative presentation and sharing your country experience as well. One of my questions is, in Thailand, you are practicing EMR tax. For instance, like from the tobacco and alcohol tax, you use the 1.5 for the broadcasting for public information, one thing, and 2% for the health promotion funding. Okay, my question is, who is the key player for the decision to use the resource mobilization from tax to the for the health promotion foundation or the this is my one question. The second thing is, in Myanmar, smokeless tobacco is the proportion of smokeless tobacco users are around about the 30% of the population is quite high. Okay, and for practicing the taxation for the smoking product like the cigarette or cigar is relatively easy. For taxation for the smokeless tobacco, I didn't know how are you using in maybe in your country. This is my two questions. Thank you.
Thanks.
This is Shanta from Nepal. First of all, I would like to thank all the presenters. It's very, very informative. I'm just asking my country-specific question. What I observed that regarding a tax increase, there is always a tug of war in between the health minister and the finance minister. Finance minister, what I observe, that very much surrounded by so-called market forces. So, I mean, there has been the cases in Nepal where World Bank play a proactive role in increasing the taxes. So my question to Mark and Nuno, especially the WHO representative, could, I mean, WHO initiate the process with the World Bank jointly so that World Bank can also pressurize the government to increase the tobacco tax in Nepal? Thank you so much.
Okay, so let's take the first, our colleague from Pakistan, and then we open up.
Fifth question, actually, you said that 5 questions will be allowed. My question to the countries is that do these countries have water pipe consumption in their countries? And also, do they have the use of smokeless tobacco? If yes, are these being taxed or not?
Okay. So the last question, Evan, you have a question? Okay, come back later, I think. So we have, I think, that a good set of questions. So I would like to begin with Thailand, since you have a specific question addressed to you as to who decides the use of the revenues that have been generated. And perhaps I will ask our colleague Jeremias Paul also to talk about it, mainly because in the case of the Philippines, earmarking is part of the reform process.
All right. Thank you. The 2 funds which is earmarked from the excise tax on alcoholic beverage and tobacco and cigarettes. These, are governed by their specific laws, and each fund has their own committees that, entitled, to apply. I mean, to use the funds according to the criteria, set of criteria specifically in the law. For example, the Thai Health Foundation Fund, expenditures can be approved, for research, that helps promote, reduction in cigarettes consumption, for example. So these are specifically, written in the law. The first question, I suppose, in the context of Thailand, whether there's a room for tax increase, or tax hike, maybe. Yes, there's a room for tax increase, because the maximum limit, by law is 90%, I suppose, and we are now at the 87%. But I'm not sure whether reaching that limit would, bring about, greater revenue, reduction in consumptions. So I was trying to say that as a, tax policy maker, and we are trying to strike a balance between revenue and control of consumption. So, depends on, the responsiveness of, consumption to the price changes. If the demand is inelastic, so that means, increase in price doesn't have any effect on consumption. Maybe, not that much effect on consumption. So it depends on, the elasticity of demand. And the last question about water pipe. I think in my country it's illegal, to sell or to consume this kind of, water pipe or, baraku, whatever. And we are, looking beyond the conventional cigarettes, the combustible cigarette, into the electronic ones. And I suppose that the new law, which is being amended, will address this kind of, new products in the market as well. Thank you.
Now I would like to invite Dr. Paul to talk a little bit about the earmarking and also address the other 2 questions briefly, and then to Professor Cornell. since we are starting to run out of time.
Yeah, on the issue of earmarking, the incremental revenues, after deducting the allocations for, under the law, existing laws for tobacco farmers, the balance essentially is a big portion of that goes to universal health care. Who determines what to spend? It's really the Department of Health. They're assured of funding, but they still have to go through a budgetary process where they have to go through a program that they will have to specify where the money will be spent. So my emphasis earlier, we need to make sure that the money is spent wisely. And they're also required to come up with a medium-term expenditure program for health. There's still a lot of things that we need to do, because I would think that we will be judged not by the amount of revenues that we would have generated, but how we have implemented the universal health care. On the issue of whether we will continue to increase taxes, of course, if we want to, but there is already a guaranteed tax increase of 4% every year after unitary, but that may not be sufficient because of as the per capita income increases, therefore you have to increase also to adjust for affordability. But for that, we have to go through Congress again, and that will be again a big fight. So with your support and with the support of the international community, we should be able to do that. On the issue of WHO and World Bank, I mean, we work closely with them, but again, at the end of the day, it's an ownership issue. That is very important, because the years of conditionality of the World Bank are over. What's really important is that countries be at the driver's seat. And the issue of water pipes and smokeless tobacco, we don't really have that much in the Philippines.
Before Professor Corney speaks, I would like to just echo what Dr. Paul indicated. The years of conditionality are a thing for the past. At the end of the day, I guess a key lesson from the three countries is that a key variable to push this process forward is political leadership, political commitment to sustain the process of reform. If you don't have that, you could have many conditionalities, but the car will not move forward. So unless you have that kind of support and commitment at the highest level to push this, not only from a revenue perspective, but more importantly, to improve the health conditions of the population as a vital human capital investment, you will not achieve the desired objectives. Corney.
Okay, two comments. Firstly, the comment about water pipe. Water pipe in South Africa is legal. It is very fashionable amongst young people. We did a survey just very recently amongst the Western Cape province, which is one of the 9 provinces of the country, and water pipe consumption was about 10% water pipe consumed in the last month. So it is not taxed in South Africa, and at the moment, e-cigarettes and other smokeless forms of tobacco are not taxed either. Then the second comment is to Constantine. Do we want to see an increase in the excise tax? Of course. But I am not in government, I'm just an academic. I do speak to government and I try and make the case. But at the end of the day, it becomes a government decision. But there has been pressure put on government from a number of sources. Of course, they get pressure from the other side as well. And I think that the other side's pressure in terms of the story that is being told about illicit trade seems to carry more weight, although that story is being undermined by research and I think by the anti-tobacco movement.
Okay, colleagues, I think we have run out of time. The final word is my co-chair.
Thank you very much. Before closing, I want to respond quickly to the question from Nepal. Mark has been to Nepal and he has sent a very good report about how Nepal's tax rates are among the weakest in the region. And we are very much willing to support Nepal, and then maybe my colleague from World Bank will be happy to work with us, and then IDRC is also there? Yeah, okay. We will be trying our best effort to support Nepal in improving tax systems. And I would like to thank all our great speakers and to the audience for this wonderful session. Thank you.
Hello? Okay. In order to stay on schedule, I would like to go ahead and get started. First, I would like to welcome you to the session, just to make sure that you're on the right one. This is Tri-Plenary 4, and the focus of the presentations this afternoon is going to be on the toxicity and health effects of water pipe tobacco. My name is Razi Zatari. I am the professor and chair of the Department of Pathology and Laboratory Medicine at the American University of Beirut, and I'm also the chair of TOBRAG, the Scientific Group for Tobacco Product Regulation, and I'm heavily engaged with the tobacco product regulation. I'm not going to say more word about myself. I would like to introduce my co-chair for this session, Dr. Dorothy Hatsumukami, who is well known to all those who are engaged in tobacco science. She is the Forster Family Chair in Cancer Prevention at the Masonic Cancer Center of the University of Minnesota, and she's a professor of psychiatry. She's also the Associate Director of Cancer Prevention and Control at that university. She's also a colleague and a member of the TOBRAG group, and she has contributed so many scientific and scholarly work in the field of tobacco and tobacco science, and with focus on a variety of topics: addiction, ends, toxicants, name it. It's a great pleasure to see her right next to me chairing this session. And with that, I would like to turn it over to her. What we would like to achieve by the end of the session is the focus on to learn more about the toxicity of the product, and at the same time try to get some information about funding opportunities for those who are interested in conducting research. There are still gaps in the science on water pipe, and hopefully the speakers can shed some light on the toxicity side and funding opportunities. I'm turning it over to Dorothy to introduce the first speaker.
Thank you. So this session is going to have 4 presentations and 3 panelists. And at the end, I will open the floor up to the public for questions and comments. So it's my pleasure to introduce Ms. Jenna Vestal, who officially joined the WHO Tobacco-Free Initiative in Geneva, Switzerland in 2003 as a legal officer and scientist. She is currently serving as a technical officer in the Prevention of Non-Communicable Disease Department of the WHO. She is the focal point of WHO's work on tobacco product regulation, which includes coordination of the work of the Study Group on Tobacco Product Regulation and the global standardization, standard-setting work of the WHO Tobacco Laboratory Network. So, Ms. Vestal.
Thank you, Dorothy. Chairs, could you please remind me when I have 2 minutes left? Can you see me? Let me maybe move sideways, or like here. Okay, much better probably. Good afternoon, everyone. We know that you have a choice of tri-plenaries, two other very interesting tri-plenary, but yet you chose to be here, so thank you for being here. My presentation is, the data here are all in this water pipe advisory note of the WHO Study Group on Tobacco Product Regulation that we're launching today. So all of the data is here. They're the result of the Global Adult Tobacco Survey and the Global Youth Tobacco Survey. And I thank my collaborator, Mr. Jeremy Morton from the US CDC, because I'm actually using his slides that he used yesterday at the water pipe workshop for this presentation. So for those who were here yesterday, I see some familiar faces. Don't tune out, because maybe the second time you're hearing this, things might even stick. Okay, without further ado, my presentation is about just giving you a snapshot of what we found in the various regions of WHO, and then giving you a global summary and pointing out some research gaps. As we know, water pipes have been used to smoke tobacco and other substances in Africa and Asia for at least 4 centuries. So for these 2 regions of the world, water pipes are not new. Water pipe tobacco smoking traditionally has been associated with older men. However, in the 1990s, starting around that decade, a surge among youth and young adults were noticed. And this is because of the introduction of flavored and sweet tobacco, that's masil. And then there was this perceived, this misconception that water pipes are healthier than cigarette smoking. And there's the novelty of the experience. It's perceived as socially bonding and relaxing. And because of this, there's now a growing concern about the increasing prevalence of water pipe. And specifically, the influx of hookah, shisha bars, cafes in urban areas in all 6 WHO regions, so not just in the 2 regions anymore. Let's go to the Afro region. What we know there's limited research on water pipe as tobacco smoking rates are relatively low anyway compared to other regions. So it's not yet an epidemic unless we don't do anything about it. Based on small-scale water pipe studies in South Africa focused on students, we know that high school students, there's 60% every use and 20% daily use. For medical students, 19% every use of water pipe were reported. And for university students, 40% current use. For our global adult tobacco survey, from now on I'm gonna just mention GATS, in Nigeria in 2012, and for adults that's defined as 18 or older, the current water pipe use is 0.3% overall. Let's go to our EMRO region. This is where we see some of the highest prevalence rates of water pipes tobacco smoking in the world. And it's especially increasing, especially among youth. For instance, there's this longitudinal study of 7th grade students in Jordan, which showed a water pipe prevalence increased by 40% from 2008 to 2010. So it's just in a span of 2 years, there was a 40% increase. And use of other tobacco products, mainly water pipe smoking, was higher than cigarette smoking among youth aged 13 to 15 in all 17 countries of the region. So if you look at this graph, this is a graph of current water pipe smoking among youths 13 to 15 based on our Global Youth Tobacco Survey from 2008 to 2014. And there's been a steady increase, and the highest of them, the highest prevalence rates, are in Jordan, Lebanon, and West Palestine. And we see an alarming increase of water pipe prevalence among boys and girls in the 17 countries of the EMRO region. And then let's compare these 2 countries because that's where we have GATS data, in Egypt and in Qatar. In Egypt, based on GATS 209, current male water pipe users is highest among older ages, 40 to 54 years old. They're from rural areas and they're less educated, and they're heavy users. 90% of current users are daily users, and the average number of water pipe sessions per week is 17. Considering that 1 water pipe session is roughly equivalent to 20 cigarette sticks, that's 200 times 17 per week, so that's quite a lot. But then in the same region, we have Qatar. Our GATS 2013 survey shows that there was no significant differences by age and education, and that the occasional water pipe user was 77% of the current users. So we need further studies to really tease that out, to understand why there are differences even amongst countries within the same region. Now going to the European region, for terms of youth, results from small-scale studies show considerable use of water pipe in Europe among youth. So for British university students in 2008, 30% had ever used. And for students aged 11 to 15 in Estonia, current use for boys were reported at 25% and for girls at 16%. Now, this is another interesting snapshot here from our GATT survey. Notice Turkey in 2008, male percentage prevalence was 4%, but then it dropped down to in 2012 to 1.1%. So Turkey has managed to decrease its prevalence. However, if you look at there, Russia and Ukraine, the prevalence rates for female is quite alarming. It's high. So in terms of overall picture for our European region, we see that the water pipe users are young adults, 18 to 24 years old. They live in urban areas, they're higher educated, and they're occasional users. And then overall for the EU citizens, 16% have reported ever use of water pipe. For our PAHO region, we have some data. Let me start with the US first. 1 in 5 adolescents will try water pipe before high school graduation. And high school seniors, 18% have reported use in the past year, and that is more prevalent among higher socioeconomic status. And for college students, 8.4 reported current use. For adults, however, that's 18 and above, 0.5% reported everyday or someday use. And let's hope that wouldn't go up. For Canada, however, for youths in Canada in 2013, while cigarette smoking significantly decreased in recent years, ever water pipe use significantly increased by 6%, a relative increase of 6% in just a span of 4 years, from 2006 to 2010. The good news is that in Latin American countries, water pipe does not appear to be common, although published literature is limited. So based on our GATT survey of 4 Latin American countries, Argentina, Brazil, Mexico, Uruguay, the prevalence overall is only 0.2%. Going into our CRO region, CRO looks like, compared to the other regions, is not a problem. It's not problematic yet, and let's hope it stays that way. However, the problem there for tobacco, as we know, is smokeless tobacco. WePro now, this is our final region, is very interesting. There's a long history of water pipe tobacco smoking in Asia. We have the traditional bong-type water pipes. They could be made of bamboo, and now more recently, with more disposable incomes, they're made of metal or glass, and they even have patterns and drawings. They're different than hookah water pipes. They're used in Asian countries such as China, Burma, Laos, and Vietnam. And it's a misperception to think that it's less harmful than the Arabic hookah version. And for WePro region, from our GATT survey, surprisingly, Vietnam for 2010 showed that it's one of the highest rates globally for males. It even trumps the rates from the EMRO region, and it's higher among older age groups. 40 to 54 years old is 18%, and from rural areas is 16.4%. And we have some prevalence data there for China and Malaysia. So globally, what's the picture? Water pipe traditionally, as we know, is associated with the Eastern Mediterranean region, Asia and Africa. And the evidence is suggesting that it's increasing now globally, particularly among high school and university students. And this is partly due to the immigration of people from Middle Eastern countries, especially to the Western world, thank you, which fuels the water pipe use in other countries such as USA, Canada, and Western Europe. And the more problematic is that there's a proliferation of shisha, hookah bars, cafes in urban areas. And the thing that is also more worrisome about this is that these venues frequently are exempted from smoke-free policies. So we at WHO have always advised regulatory agencies to make sure not to exempt shisha and hookah bars from smoke-free policies, because this just undermines Article 8 of the WHO Framework Convention on Tobacco Control. 2 slides pointing on research gaps. There's a lack of published nationally representative studies on water pipes. So for example, There was a study, they did a literature search, they found 38 studies on water pipes, but only 4 were conducted at national levels. So what can we get from that? That means the studies were mainly on specific subgroups, such as university students. So we don't have enough data for adult use. And it's important to continue monitoring at national levels in order to inform targeted tobacco control interventions. And to do this, we need to continue to track trend data for youth and adults through our GYTS and GAT survey, and also to integrate tobacco questions for surveys in any national monitoring tool. And to use that not just as a one-time shot, but to get trend data and use it every 2 years or 3 years. I think that's the end. Thank you so much for your time.
It gives me great pleasure to, thank you, Gemma. It gives me great pleasure to introduce the second speaker, Dr. Alain Shhadi, who is a professor of mechanical engineering at the American University of Beirut. And he is the one who founded and directs the Aerosol Research Lab. I guess Alain does not need much introduction for anybody who knows anything about water pipe or the science on it. He has contributed in so many ways to the study of the toxicity, as well as a lot of variables that have to go into the understanding the biology, as well as the psychiatry that is associated with the use of this form of tobacco. And more recently, Alan has been focusing on a number of research studies trying to develop methods for predicting toxicant yields and exposure of modified risk tobacco products, including that of electronic cigarettes. Alan, the floor is yours, and we're looking to hear your presentation on the real-time water pipe tobacco smoke toxicant sampling in the natural environment.
Thank you, Ghazi. I'll be talking about water pipe tobacco smoke toxicants, exposure, and effects. I have 5 questions that I'd like to address in the 10 minutes that I have here, 2 minutes per question. First, what is a water pipe, to make sure we're on the same page? Second, does water pipe smoke contain toxicants? Third, does it deliver toxicants? Fourth, does it induce acute and long-term health effects? And fifth, are tobacco-free water pipe products any less harmful? So this is a schematic of a water pipe. The main components are the head, the body, the bowl, and the hose. When a person inhales from the mouthpiece of the water pipe, air flows over the charcoal. The charcoal combusts, it releases its fumes, and hot air, it goes into the tobacco, where the volatile components of the tobacco and the tobacco mixture are vaporized, and then it cools as it passes through the body of the pipe and into the water, and finally to the person using it. I should mention that the tobacco is not really just tobacco. It may be only a third tobacco, with the balance being flavors and humectants like glycerol. So going to the first question, the second question, does water pipe smoke contain toxicants? If we read the packaging, we might be led to think that it contains no toxicants other than nicotine. And you'll see here, and this is typical of the packaging that we see, it says 0.05% nicotine. It's not clear what that refers to, whether that's by mass or by volume. And it says 0% tar, and technically speaking, there is no tar in that package because it hasn't been smoked yet. But if we really want to know what's in the smoke, we have a couple of approaches. One of them is to find out how people smoke water pipes. Second, to program a robot to smoke the same way. And then to analyze the smoke for toxicants. And this would be kind of a schematic of it, and you can see a human puff topography record up here. That's just recording how people smoke, and then we can input that into a computer which will reproduce that same smoking session. And I won't talk more about that because Marielle will be introducing more about methods. A second approach is what we call real-time sampling in the natural environment, and that's where we've developed a device that we connect to the water pipe, and we We approach people who are smoking in cafes if they would mind that we sample their smoke while they're smoking. So we would collect about 2% of the smoke during the session. And regardless which approach we take, we find that water pipe smoke does contain toxicants, and it contains a lot of them. So this is tar, nicotine, and CO, comparing the water pipe in red to the cigarette, to a single cigarette in black. You can see that there are much higher levels with a single water pipe. That's a typical 1-hour water pipe session. And it contains more of just about everything else that we've looked at. Polyaromatic hydrocarbons, volatile aldehydes, heavy metals, and it contains actually less tobacco-specific nitrosamines than a single cigarette. And we'll keep that idea in mind. I should mention also that these components are associated with a wide variety of diseases, from lung cancer to COPD and other effects, including cardiovascular disease. Another thing we know about these toxicants is that they're delivered in small particles. If we actually compare the particle size distribution of water pipe to cigarette smoke, we find that they're very similar. So to the extent that to the extent that the particle size affects the deposition in the lung, we should expect similar deposition patterns. We also know that the particles are biologically active. For example, they induce oxidative stress and inflammation in human aortic cells, which leads to cell cycle arrest, and then, very importantly, dysfunction in the cells, so impaired vasodilation, impaired angiogenesis. And what we know enough to know that these are plausible mechanisms for vascular disease in regular smokers. All right, are tobacco-free water pipe products any safer than those scary numbers I just showed you? And if you, again, read the label on the package or read the advertising, it would say something like, it provides the same flavorful smoke found in other shisha, but without the harmful effects of tobacco. And when we look at the toxicant profile, and there again it says it's free of nicotine, tobacco, and tar. If we look at the toxicant profile and we compare it to the tobacco-based products, we find that it's virtually an identical toxicant profile to the tobacco products, except that it has no nicotine. Otherwise, it's more or less the same. You can see the probability values for the differences when we did a study of this. It also, not surprisingly then, has the same biological activity as the tobacco-based products. All right, so does it contain toxicants? Clearly the answer is yes. And I won't go back over the points I just made, but I can cover those again later. All right, next question. Does water pipe smoke deliver toxicants to the body? So to know that, we need to know, rather than knowing what is in the smoke, we need to know what's in the smoker. And in these kinds of studies, urine, blood, exhaled breath, and we look for markers of exposure to those toxicants. Because if someone inhales those toxicants and then exhales them right back out again, maybe there wouldn't be such a strong delivery to the body. So there are placebo-controlled studies in the clinic. There are comparisons to cigarettes in a hospital setting and observational studies in populations. I'll just point to a few of those. This one shows carbon monoxide and nicotine in a single-use session in a clinical setting. So what you're seeing there is from the onset of smoking to 45 minutes into a smoking session, you see carboxyhemoglobin rises drastically, as does the plasma nicotine. So indeed, toxicants are delivered to the bloodstream. Compared to a single cigarette, you'll see here the carboxyhemoglobin delivered in 5 minutes of water pipe smoking is already much greater than a single cigarette, and of course the water pipe continues well beyond that 5 minutes. And we see a different pattern with nicotine. We see a much more rapid delivery of nicotine with the cigarette, but we actually reach roughly the same peak levels with the water pipe. And if we compute the area under the curve, including the decay period, you'll find that the exposure, the total exposure, is about 2 to 3 times that of a single cigarette in terms of nicotine. Another study in a hospital setting where they looked at 13 dual users, you'll see they were allowed to smoke 3 water pipes during a single day, and they were allowed to smoke as many cigarettes as they wanted throughout the day. And what we see is that, again, plasma nicotine reached higher levels with the cigarette users than with the water pipe users. but it reached much lower carboxyhemoglobin levels, or exhaled breath CO with cigarette than with water pipe. So slightly higher nicotine and slightly lower and much higher CO. Carcinogen exposure, interestingly, we have tobacco-specific nitrosamines higher with the cigarette than with the water pipe, and the opposite with polyaromatic hydrocarbons, higher with the water pipe than the cigarette. We see similar results in populations that have been surveyed, where we see the cigarette users tend to be exposed to higher levels of tobacco-specific nitrosamines than water pipe users, but nonetheless, water pipe users are exposed to significant levels. So they do deliver toxicants to the body, and so we've seen that in clinical, hospital, and natural environment, and the findings are consistent with one another across those settings. And interestingly, the findings are generally consistent with what we learned about the toxicants in the smoke. So that is, if there were more nitrosamines in the smoke with a cigarette than with a water pipe, we also saw that in the user, and vice versa with carbon monoxide and all the other toxicants. So that gives us confidence that both there are high levels of toxicants in the smoke and that those toxicants are delivered to the body. Do they have health effects? Well, we know the nicotine is physiologically active because we see the heart rate rising during a smoking session. We know that it's psychologically active. It suppresses the urge to smoke, for example, both with water pipe and cigarette. And we know that it interferes with central nervous system control over the heartbeat, as measured by heart rate variability. If we compare sympathetic activation as well as reduced complexity, that is sample entropy of the heart rate variability, we'll see that during a smoking session, those are suppressed. And that's true regardless whether the person is smoking tobacco-based or tobacco-free water pipe. So that's also consistent with what we learned about the toxicants. It induces inflammation and oxidative stress in mice. Water pipe smoke is much higher than the control, as you see in these graphs. And it's similar to what we find with cigarette smoke. So it's associated with a bunch of other health effects: genotoxicity, reduction in exercise capacity, reduction in lung function. And does it have long-term effects? The answer is, it appears to be yes. As Gemma pointed out, there's a lack of high-quality longitudinal studies on this topic, but there are associations with a variety of long-term diseases like ischemic heart disease, emphysema, lung cancer, and a whole host of them. This is reviewed recently in the current issue of Tobacco Control. There's a supplement on water pipe smoking. And just to kind of summarize, Iliad has written, a wide range of diseases have been associated with water pipe tobacco smoke, but research in this area is relatively underdeveloped and a better evidence base is needed. And there he's referring to long-term health effects of water pipe smoking. So thank you for listening.
Thank you, Ellen. That's very valuable information because of the misperceptions that some of the consumers have over water pipe use. Our next speaker is Marielle Brickman, who is a senior research scientist at Battelle in the US and has over 25 years of experience designing, coordinating, and managing human exposure studies. She has focused specifically on tobacco-related exposures for the past 14 years and has developed novel real-time techniques to non-invasively analyze exhaled breath samples. She has used these techniques to compare active and passive exposures from many different tobacco products. So there you are.
Thank you, Dorothy. Let's see. How do I?
Just advance. Go down. Oh, yours is not here. Oh.
There we go. Thank you. Thank you, Dorothy, and thank you for the opportunity to talk with you about some of the work that we're conducting at the Battelle Public Health Center for Tobacco Research. Today I'm going to be talking to you about a tool that we developed, the research-grade water pipe. I'm going to give a brief summary of why we think it's important, and then I'll show you some data that we generated to answer the question, how do the pieces, parts, or components of a water pipe affect not just the smokers' exposures, but also non-smokers in the same environment. Next, I'll give some highlights of a clinical research comparative exposure study that we conducted where we evaluated 2 accessories that manufacturers claimed reduced harm. And finally, I'll leave you with a comparison of side stream smoke exposures from water pipe versus cigarette smoking. So why go through the trouble of building a research-grade water pipe? Well, commercially available water pipes around the world run the gamut with respect to design, materials, air infiltration, or leakiness. And we wanted to conduct machine and human smoking comparative exposure studies to see if we change something about the water pipe, how will it affect smokers' exposures? How will it affect environmental exposures? So in order to conduct these systematic studies, we needed to standardize and reduce the variability inherent within the smoking equipment as much as possible. We also wanted to understand how changes in human puffing behavior how changes affect human puffing behavior. So we incorporated an inline topography device to collect those data. So we determined the precision and accuracy of the research water pipe using machine smoking. This is an example of one of our validations, this graph of coal and tobacco consumption during 1-hour machine smoking sessions. The variability across 24 sessions is very low. It largely falls within 2 standard deviations of the mean. These data were produced using the smoking regimen Alan Shihade developed from measurements made of naturalistic cafe smoking behaviors. And just about all of the constituent data that's reported in the literature was produced using Alan's machine smoking regimen. So once we optimized the precision and accuracy of the research water pipe, we invited experienced water pipe smokers into the lab and had them smoke as they normally do. Only we restricted them to a single coal. So they used our research water pipe because we wanted to determine is Alan's smoking regimen accurate for our research water pipe. So when we looked at their data, we found something that Alan and Wasim Maziak have already both reported, which is water pipe smoking behavior is not homogeneous throughout the session. Smokers smoke more intensely in the first third of the session, and then they settle in to take smaller and less frequent and intense puffs in the last 2/3. The resulting smoker averaged puffing regimen that we collected is shown in the table there. And then I'll compare that to Alan's Beirut regimen, which is on the bottom in orange. So in the first 11 minutes, our smokers took much longer, larger, but less intense puffs at roughly the same frequency. And then in the final 2/3, puffing rate slowed down. So although we're seeing an overall similar pattern, which is more intense smoking in the beginning, our smoking regimen draws roughly half the total volume through the water pipe as compared to the Beirut method. So now we have a tool of known precision and accuracy, the research water pipe. We have a smoking regimen that is based on the human puffing behavior that was measured using this tool. And these 2 things allowed us to perform a systematic evaluation of the effect that different water pipe components have on constituent yields. The table shows the 4 components that we have evaluated, but I'm just going to focus on the electric coal versus the charcoal. This shows the setup of our smoking room. It's an isolated room from the rest of the laboratory. It has a separate air exchange. It's well mixed. The coal is weighed, lit, and placed on the research water pipe using a glove box type apparatus, so that prevents our laboratory staff from exposure to toxicants. The smoking machine, which you can see there in green, is controlled using our human topography-based puffing parameters. It's located outside the chamber. It takes a puff, and the resulting mainstream smoke is sent to the particle monitor on the left, shown in blue. And the particle monitor not only continuously records the size distribution of the mainstream smoke, it collects these particles for later size-specific chemical analysis. And then In pink and gray, we continuously monitor the smoking chamber or the room environment for volatile chemicals, including carbon monoxide, benzene, 1,3-butadiene. And here's a real-time trace, an example of the carbon monoxide concentration. You can see as soon as the coal is lit, carbon monoxide shoots up to over 120 ppm. Keep in mind, these are the emissions from just a single water pipe. Imagine what the levels in a cafe might be with multiple pipes, or daily users and the non-smokers that live with them. So what did we find? We'll look at the side stream results first. The carbon monoxide is on the left. Again, this is the total mass of carbon monoxide that was emitted during the machine smoking. Over 2,000 milligrams of carbon monoxide. But if we look at the electric coal results, and that's shown in green, we see that the carbon monoxide isn't even detectable. And in fact, if we look across the rest of the volatile organic constituents, we see lower levels across the board for the electric coal. So let's move to the mainstream. Now this is what a smoker would inhale if this was not machine smoking, if someone was actually in there smoking the hookah. Electric coal, again, looking at the right side of the graph there, we see decreased TSNA and decreased PAH exposures across the board. But looking on the left, we also see decreased nicotine. In fact, we see the electric coal produces about 1/5 the nicotine as a charcoal heated water pipe would. So on the face of this, it looks great. All we have to do is switch to electric coal and we reduce harm. But I want to keep in mind that the data that I just showed you was from machine smoking using a single topography, and even though it was based on human puffing behavior, it was behavior recorded for the research water pipe that was equipped with a charcoal heating source. So it's very important that we remember the hard lessons we learned with light and ultralight cigarettes. Humans don't smoke like machines. In fact, humans titrate their nicotine dose through compensation by taking larger and more frequent puffs. This is well established for cigarettes, but is it true for water pipe? So to answer that question and to evaluate manufacturers' claims regarding the electric coal, which is advertised as a reduced harm accessory, we used a small cohort of experienced water pipe tobacco smokers. These were college students with an average age of 25 years and a crossover longitudinal design. They came into the lab, they were randomly assigned to the electric coal or the charcoal, and then a week later they came back, they switched and smoked the opposite configuration. And although we did look at the bubble diffuser, I'm just going to focus mainly on the electric coal. So we're looking at the boost in plasma nicotine. Before we talk about the results, I want to point out that both the standard and the bubble diffuser configurations use charcoal heating. So we look at the participants' plasma nicotine, we see that the electric coal results in half as much boost as the charcoal heating. Now, how is that possible? If you remember, the mainstream was only 1/5 as much. So we look to the right there at the total puffing volume. Total puffing volume is almost double. These smokers are engaging in compensation. They're taking larger and longer puffs over roughly the same period of time. We see this exact same behavior when someone smokes an ultralight cigarette. So I'm just going to wrap up here. Alan has already showed a comparison for mainstream smoke. These are side stream exposures. So this is not just what smokers experience, but the people around them. The number in the orange column, if it's greater than 1, then the chemical is present at higher levels in water pipe smoke. These are carcinogens, respiratory, reproductive, and developmental toxicants. And the numbers actually are conservative because this is side stream only. This does not include what smokers exhale into the room. And if you remember, that could be on the order of 115 liters of smoke for a single smoker. So all of these chemicals are present in the air. If someone is smoking water pipe, this is what bystanders are breathing. And this is particularly ironic considering that there still exists a perception that water pipe is less harmful. Moving from gas phase, this shows the semi-volatiles. Also, these are all side stream data. This is Nancy Dare's data from Alan Chihade's group. And again, you see that on the very bottom column there, it looks a little misleading, but what that's indicating is that water pipe also has smaller sized particles, which have a greater health effect. So in summary, there's a great deal of evidence indicating that water pipe tobacco smoking exposures exceed those from cigarette smoking, not just for the smoker, but for anyone that's in the room with them. Secondly, not all water pipes are the same, and the different components can have a significant effect on the chemicals that smokers and bystanders are exposed to. And lastly, harm reduction claims must be supported by evidence, not just from machine smoking studies, but human studies, so that we can understand if compensation is taking place. I'd just like to acknowledge and thank my collaborators for all their hard work, and especially thank NIH and FDA for the funding that made these studies possible. Thanks.
Thanks, Mirella, for this very informative presentation, which adds another dimension to the understanding of the chemistry and the toxicants that the smokers and the people in the surrounding are exposed to while using this tobacco product. I'm sure there'll be room for more questions and discussion later on. In order to stay on time, it gives me a great pleasure to introduce our next speaker, who is Dr. Rachel Grana. She's the Program Director in the Tobacco Control Research Branch of NCI, a research funding agency which is part of the U.S. National Institute of Health. And her research is focused on behavioral and psychosocial factors associated with tobacco use. She has done some elegant work on e-cigarettes and how they affect the novel use of these tobacco products. And for this afternoon, she's going to enlighten us about funding opportunities for the water pipe tobacco research. Grana?
Thank you so much. I'm delighted to be here today to share with you what I have learned about the funding opportunities for water pipe research. Again, I'm from the National Cancer Institute. This talk is my views and my research and not the official positions of the National Cancer Institute. So I'll just begin highlighting again the importance of this research, but we've had a lot of that at this conference, which is wonderful. The basics of a funding opportunity, organizations that have funded tobacco research with water pipe tobacco research examples, and conclusions and future directions. So over the past 20 years, water pipe use has increased dramatically, and we've seen some of these data presented already, but I think what has been impressed upon me at this conference in particular is that the concern about youth uptake, and in some countries in the Eastern Mediterranean region, this use has even surpassed cigarette smoking. And in the US, for example, and in some other countries, water pipe use is occurring in the context of multiple tobacco product use, especially among youth, which is also of great concern. And the two presentations that preceded me about the health effects are very convincing, again, about the need to conduct more research in this area. So as we know, the WHO released a landmark report, an advisory note in 2005 that called for 12 research priorities and outlined these for us. And actually revised recommendations will be launched today. Exciting. And some highlights from the research needs that were identified in the advisory. These range from increased research needs in identifying the type and patterns of use, as well as toxicant yields and biomarkers of exposure, the relationship between water pipe use and other tobacco product use or other drug use, and then of course the increased need for research in the development of prevention measures and treatment interventions. So in recent years, we've also seen a commitment and actions and efforts to convene researchers and other tobacco control experts in addressing this problem. Some of these conferences, international conferences, have been hosted in this region, and the advisory is being updated and has been updated, and then this issue was addressed at the recent COP6, which shows that there is a global effort undergoing right now. Okay, so getting into a little bit of the funding opportunities, I thought that I would start with, if some of you haven't applied to a funding opportunity before, just the basics of applying to a funding opportunity and what that entails. I am from the US, so I will just use my own agency as an example for the basic process. So it might be different at the other agencies, but some similarities, of course, will prevail. At the NIH, we're comprised of 27 institutes and centers, and each of those this is a government agency, I should say. Each of those institutes and centers have their own research priorities and needs. So what you would do as an applicant is you would go to the institute that might be interested in funding your research and really read about the priorities on the website, and you can call people like me, a program director, to give you more insight into that. You'd prepare your application, submit that application, of course. Your application is reviewed by a panel of scientists who are with expertise relevant to your application and scientific area. Then the funding selections would be based on merit assigned by the peer review, as well as the priorities of the institute and center with their limited research dollars. And that's just the basics. So this is just an example of where you might find that information. You can put in keywords or the institute and center to find these funding opportunities. And for instance, at the NIH, we do actually fund global health research and research from non-US institutions. So often these are in collaboration with an investigator in the US, and often also they address a research question or conduct basic research that will have broad implications and would be very useful to the US population as well as to the foreign countries' population. And I've included these links here, and of course I'm happy to give more links and resources afterwards. So in the funding opportunity announcement, you'll see a portion, looks like the part in the middle of the slide, that would identify whether this opportunity announcement is eligible for foreign institutions or foreign in collaboration with US institutions. And again, I just want to note that before you put an application in, the application process, for instance, in the US is, at the NIH is pretty intense, I would say, and has a lot of steps and forms, and we really encourage people to contact us to assist you. And I should also say that, when submitting from a foreign institution, it is important to partner and make clear all the partnerships that are involved as well. At the National Cancer Institute, we have a new Center for Global Health. I thought you might just be interested in knowing about this. The mission is really to support a cancer control research agenda and capacity building agenda in other countries, and particularly low and middle income countries. And so this is a really great new effort with our institute. And some of the projects are tobacco control related. So again, the current situation with water pipe tobacco research, investigators are always encouraged to send what's called unsolicited proposals to our parent announcement. So most of the research we fund actually is investigator initiated, or a researcher with a great idea that submits to us, not in response to a specific call for your particular research area. Currently, there is no specific water pipe tobacco research funding opportunity, but water pipe tobacco research is at our institution, and it is definitely, you would definitely be encouraged to apply. We have funded in the past 14 years 30 grants that either exclusively address water pipe tobacco use or in part address that, and some of these are also funded by the FDA with the NIH to address tobacco regulatory priorities as well. Here's some sample topics: assessment of use in youth and adolescents, standardized methods, identification of toxicant exposure, biomarkers, and then an epigenetic effects of smoke in human respiratory epithelia study. So another program that has implications for this talk is the International Tobacco and Health Research and Capacity Building Program, which these are projects that were awarded throughout the world in diverse regions, and they were implemented in low and middle income countries with high income country collaboration, and really to build capacity for tobacco control research in those countries. And this is just an image of a recent newsletter in March, April 2014 that highlights one of these first funded projects, which is by Dr. Wasim Maziak. on waterpipe and, well, he has a whole grant about tobacco research in the Eastern Mediterranean region, and one part was about waterpipe tobacco use. And this is really highlighted and appreciated at the NIH. Okay, so moving then from, of course, the NIH example to global funding opportunities. I should say that I have to give a big thank you to the people I reached out to. My methods were reaching out to experts and funders around the world that would have knowledge about waterpipe tobacco funding opportunities. And this is by no means an exhaustive list, and I didn't conduct a completely exhaustive search. This is an example of some of the people and regions I was able to reach out to. So for instance, in Canada, the Canadian Institutes of Health Research, which is sort of a similar institution and funding model to the US NIH, they have an open call for applications, open announcement. They actually fund some tobacco research. You might be familiar with the ITC studies. And right now, they do not have a specific call for waterpipe applications. In Canada, there's also the International Development Research Center, which supports research in low and middle income countries, including tobacco control. And this research is initiated and led by research in low and middle income countries, sometimes have high income country collaborators. One great example, actually, is our colleagues at the American University in Beirut are conducting excellent research funded by this center, and some of the research focuses on waterpipe tobacco research. And you can contact them for more information. In the Eastern Mediterranean region, there's also research funding that has been dedicated to tobacco and waterpipe research from two organizations, the Qatar National Research Fund, as well as the Hamad Medical Corporation. I am informed by colleagues that have been funded by these mechanisms that requires a Qatari partner or local partner, and some of the funds need to be dedicated in Qatar. And also, these organizations have hosted and been involved in convening the research conferences about waterpipe smoking research. So thank you. And the last opportunity that I was able to identify and might be of interest is the Global Alliance for Chronic Diseases, which is it's an alliance of funders that commit to funding on a particular issue and convening and giving opportunities for dissemination and meetings and partnership. Calls for proposals. There was a call for proposals that just closed in February about the prevention and treatment of lung disease. And of course, this in part focused on tobacco and as a very important determinant, of course, of lung disease. And these interventions and their implementation went to the prevention and treatment of lung diseases in low and middle income countries or vulnerable populations in high income countries. And actually, in the list of tobacco products that were relevant for study, they did include waterpipe. So looking ahead, some of the important needs, I think, for the waterpipe tobacco research and control is really not just, of course, to support interdisciplinary science and research, but also to support global networks of funders and researchers to really build capacity, with one of the examples, of course, being that Fogarty International Center's TOBAC program I was telling you about. And then also to really create momentum for dissemination and utility of the research results across regions. So thank you so much. I think there's progress that has been made, but there's definitely more need for waterpipe tobacco research funding. Thank you.
Thank you, Rachel. That was really informative to know that there are so many funding opportunities that might be available to the people out there. Now we're going to go into the panel phase of this session. And our first panelist is Dr. Faraz Avari, and he is the Director of the Cancer Control Office and the Chief Pulmonary and Critical Care Section at the King Hussein Center and Director of the Respiratory Unit. He also serves as the Regional Director of Global in the Eastern Mediterranean region. Dr. Harari has technically supervised the development of the Jordan Guidelines for Tobacco Dependence Treatment, which was recently launched in Jordan. He has been a temporary advisor for the WHO on a new advisory note on water pipe tobacco smoking. And he's going to be talking about the water pipe epidemic in the Middle East.
Good afternoon. What I would like to do in the next 5 minutes is actually give you a snapshot to what's happening in Jordan mainly. So water pipe in Jordan is on the rise. If you look, for example, at these numbers, and you're going to see variable numbers depending on what statistics you're reading. But for example, if you look at water pipe use, current water pipe use among university students, we can see that those numbers now is exceeding 42%. And as a general, if you look at all the EMR region and you compare Jordan with other countries, you can see in terms of nursing students, for example, that numbers is also exceeding 40%. Prevalence in Jordan among adolescents ages 13 to 15 years, 27% of males and 16% of females, while 44% have access actually to water pipe at home and 15% have access to water pipe in coffee shops. These are actually very scary numbers, and some of the data and evidence that we have, it really shows that among females, those numbers are increasing significantly. In a study that we conducted in Jordan among 120 female 6th grade students, 13% actually admitted that they smoke water pipe at home with their parents. So those are really alarming numbers. We can see those numbers happening among really a legislative dilemma and a problem. We have lack of standards, so Jordan now is working on standardizing the massil and the tobacco products that are used in water pipe. There are similar standards now, I think, in some of the countries in the Gulf region and in Egypt. The taxation system for water pipe is really poor and not well developed. For example, we only tax the water pipe equipment with 16%, just like any sales tax. So we need to develop the taxation system there. In addition, the massil, as you can see, for each 1 kilogram, only $5 is charged in terms of taxes. So that's also a very small amount of taxation on the massil. Coffee shops are being licensed. The licensing process is not really very clear, and it's been really controlled mainly by the Ministry of Interior for security reasons. This process also needs to be regulated. All that is happening among also lack of public support. So if you look at, for example, what is happening in with regards to public support among other areas in terms of regulating tobacco smoke in public places, you can see that the public is really supportive, whether they are smokers or not. But when it comes to coffee shops, that support significantly drops, indicating that really the public has not been reached very well when it comes to the harms and the effects of water pipe. Again, this is happening also with an aggressive tobacco industry. As you can see that some of the big giants of the tobacco industries are moving into the water pipe markets. For example, Japan Tobacco now is investing in water pipe and shisha massil components. This has also been supported by other aspects, such as the big support from, or at least the aggressive efforts from the coffee shops that are really now launching campaigns in Jordan against the regulation of tobacco coffee shops and the sales of water pipes. For example, the mayor of Amman tried to launch a campaign against the coffee shops that was faced by another campaign from the sides of the coffee shops, as well as the legislative body in Jordan that called for re-examining the law in Jordan with regards to smoking in public places in general, as you can see from these titles. 13 deputies called for allowing nargile in restaurants and cafes. They called for being reasonable when legislating, and that the House panel is working on a compromise to allow nargile in designated areas. And they actually did reach to that compromise, unfortunately, but we're hoping that this would be only a step towards the banning. Again, local tobacco industry in Jordan, also moving into the market of waterpipe and mussel, and actually selling part of their company to Philip Morris, and for one of the reasons actually to cut losses and focus on the waterpipe market. And as you can see, this is also happening with lack of regulation when it comes to advertisement. So this is all happening, for example, at the airport in Jordan, at the duty-free shop, where you can see the nice colors and advertisement for the products for mussel and flavored tobacco that is used specifically in waterpipe. This is again the delivery for waterpipe. As you can see, the use of social media and Facebook. So this is just a snapshot that I thought I should share with you. Thank you.
Thank you. You certainly do illuminate the challenges that we face in this area. Our next panelist is Tanya Cavalcante, who works at the National Cancer Institute, that is INCA, which is a body of the Brazilian Ministry of Health. Currently, she is the head of the Executive Secretariat of National Committee for Implementation of the WHO FCTC. She has been involved in the implementation of legislative, economic cessation measures for tobacco control on a national level, and is also engaged in the preparation of the Brazilian delegation for the FCTC negotiation and the FCTC Conference of the Parties. So.
Thank you. First of all, I'd like to thank for the organizer for this opportunity to be here to share with you kind of a picture of the situation of water pipe in Brazil. And I must confess that I am much more concerned than before, because I tried to pick up some information that I'm going to share with you, and I'm much more concerned than before the preparation of this presentation. A little on the context of Brazil. Brazil is a mega country, 200 million inhabitants. Conventional cigarette is the most consumed tobacco product. We have been decreasing the prevalence of smoking from almost 35% 1899 to 15% 2013. And there is a high level of knowledge on cigarette risk among the population in Brazil. But however, water pipe popularity is increasing among youth, fed by the myth that it's not harmful. Here I brought this media article, in a magazine article, showing that some aspects that is making water pipes so popular. It can be smoked in groups, sweet aroma, and smoking nargile or water pipe, nargile is much more common term in Brazil, does not cause harm. Here, I don't know if it's clear, but I make a kind of search in the Google Trends in Brazil, and we could find very clearly that the interest, the research search volume in the internet in Brazil increased from 2005 to 2014. And here we can see also some places in Brazil that has much more interest than other places, such as Brasília, that's the capital of Brazil, Mato Grosso do Sul state, Paraná, and São Paulo state. So we could map also with this tool, the Google Trends tool, where there is a much more interest in searching in internet the issue of water pipe. And we could see, for example, in Brasília, there is lots of coffee shops and restaurants and bars. Here we have Dubai Nargile Bar. This is very, very interesting. Shisha bars. So there is a lot of, this is a kind of fever of restaurants and bars consuming nargile in Brazil. We could find also some data, some information, not data, but that there was an increase of Brazilian importation of nargile if you consider 2006 to 2007. We had a total amount of $18,000 in 2006, and now in 2007, this increased to 125, coinciding with the data from the Google Trends. And also, there is smuggling from Paraguay. Paraguay is a neighbor country of Brazil, where there is a very huge cigarette smuggling for Brazil. And now we could find some news on how the federal policy is also seizing the nargile essence for being used in some bars and restaurants. Looking for the words nargile, comprar, nargile, or buy in the Google, we could find at least in the page 27 different sites of sale with Brazilian extension, com.br. So this means how this market, here only an example of a nargile website, the largest one. And you can see that there is a very important aspect appealing for youth. And also the question, when you open the screen, the question that appears, are you older than 18 years old? Yes or not, you can choose and nothing happens after that. You choose yes and nothing happens. You can go ahead and buy nargile for beginners. Also, it's another Brazilian website that sells water pipe. I'm using the term nargile that's much more common in Brazil. Increasing popularity among youth, you found a lot of video in YouTube, Brazilian boys teaching how to use, how to clean, how to do everything regarding to teaching others. It's very homemade videos teaching others how to use. Gender appeal, I'm very surprised with that because I didn't know Brazil, there is a kind of festival in Brazil. I didn't know that. It was very important for me to have this kind of immersed in the issue because I didn't know how deep was the problem in Brazil. And hookah party in Brazil, this is the 3rd edition. So this is very, very, very concerning for us that use tobacco control policy. Regarding the regulation, we have the water pipe is products to use in the water pipe are covered by the Anvisa regulation. Anvisa is the national agency that regulates tobacco products. And Anvisa prohibits additives in tobacco products, so it also includes nargile. And also the sale of stones to flavor nargile. There is a very recent regulation. The smoke-free federal legislation published in May 2014 included expressed the prohibition of nargile consumption inside enclosed places. But we can find here, just to illustrate, that's how difficult it is to deal with this prohibition, mainly in the restaurants and bars that use nargile. This is a case of Brasilia. That's the highest level of search for the water pipe in the internet and also. And outraging groups on that, like in Jordan, we can see many sites, groups posing themselves that are outraged by this prohibition. So this is a kind of situation. Regarding the data, I'm going just to present here. We have 1.2% of the prevalence in 2008. The GATT global, but the GITS, it's much more concerning. We have among the students that that smoke and other products than cigarettes, there is a preference, a higher preference for water pipe. This is the same issue in the global health professional students. There is also an interest for, I'm going to speed up just to finish. And here we have a kind of the first national campaign we did in 2013. The campaign, it seems harmless, but smoking narghile is like smoking 100 cigarettes. It was very, there was a very huge impact in the media on this message. And just some conclusions. In Brazil, there is a thriving water pipe market. Hookah is the most common non-cigarette tobacco product. There is the perception that is harmless. Young people, they are the most vulnerable group. There is a good response to the awareness campaign. And compliance to smoke-free needs to be enhanced in bars and restaurants. And questions on narghile use should be included in national health surveys in a regular basis. Thank you.
Thank you for this information on the state of water pipe use in Brazil. I'll have a few questions later on if we have the time, but it gives me great pleasure to introduce the last panelist for this afternoon. Dr. Lawati he holds MD degree from the University of Glasgow and also a Master of Public Health from Johns Hopkins School of Public Health. He has been pretty active in the field of public health at the Ministry of Health in Oman since 1998, and he has been very instrumental in introducing many policies and regulations against tobacco use in that country. And he's a well-known figure not only in Oman, but also in the region and international scene. He has been also active and engaged with FCTC from its day of inception. I'll turn over the floor, Jawad, hearing about your experience in Oman. Thank you.
Thank you, Dr. Ghazi. I don't know how this works now. No. Okay. Just press enter, right? Okay. So I'm just going to give you the flavor of things about water pipe smoking in Oman and in parts of the Gulf. So this is Kuwait. You can see the whole, as Gemma said, that was a habit of the old people. And that obviously many pictures show it has been a habit of old people. This is from Iraq now. But it moved now to a younger generation, as was highlighted by the previous speakers. And even when we have the Arabic Spring, shisha still goes on. So in Oman, where I come from, everything was banned. You could not, before 1970, nobody could travel by vehicle or wear Western dresses, and also smoking was forbidden. So anybody would smoke this sultan, which is here on the right side, he would jail the person immediately, no questions asked. So that was before 1970. However, this was not sustainable, so we, instead of jailing people, we joined the FCTC. So that was a much more feasible option to do. And you would notice that prevalence of tobacco use in Oman is small. Many data from, or many surveys, even data from the World Health Organization, which are the one you are seeing now, show Oman at the bottom of the list, whether it is tobacco smoking in adults or in youth. And also these are data quite old if you look at them. Also, Oman has the lowest prevalence of smoking in Gulf countries, whether they are male or female, or actually male. The reason for that, I think, is because of the policies of the previous governor, Sultan, and also Oman has a different sect of religion. They are the Abadi sect rather than the Sunni sect, as is shown here. You can see Oman here has a different color. These are the different sects of religion of Islam in this area in the Middle East, and you can see Oman is a different color. So that's at least my explanation. And you can see also the epidemic of smoking basically is in people from 20 to 50 or 49. Now, water pipes cafes have been spreading in Oman quite a lot, and you can see these are the different regions of Oman, and you can see the increase in coffee shops or water pipe coffee shops by 38% between 2008 and 2013. And the taxes, or they only have to pay a yearly 10,000 in Muscat in the capital area, and only about $4,000 to $5,000 a year to the municipality to get the license done. So we have been successful in banning cigarettes in Oman, but not shisha or water pipes. And this survey, which was done with the Johns Hopkins School of Public Health, everywhere they comply, except you can see the last bar, which is the shisha coffee shops. Otherwise, everywhere tobacco use is not allowed. So this is a typical cafe shop which you get in. You go in, you have a buffet or whatever, and then you can sit and smoke like these ladies are doing, looking off water pipes. And I think they are throughout the Gulf. So in terms of health warnings, there are 2 health warnings at the moment which are used in the GCC region, which are used on tobacco products, particularly for water pipes. The other ones are for cigarettes. This is the latest one. You can get shisha condoms and flavored by shisha. So this is a new breakthrough, which we confiscated in some of the shops in Oman. I didn't know Omanis were that naughty until I saw this, actually. So there you go. This was a study a few years ago where even people who smoke shisha, they were agreeing to disallow shisha in enclosed public spaces. About 88% of the people disagreed for shisha to be served in closed public places. Nowadays, we get a lot of complaints from the houses which are near the shisha or the water pipe shops, and they complain, they file these request signatures saying, we are very tired of this, we get a lot of smell coming to our houses, especially during winter time when people open their windows. So this is just a picture of it. There has been a case against, at one point in 1999, Oman banned all coffee shops, just exactly how Sharjah did. You heard about a couple yesterday that Sharjah banned smoking of water pipes throughout the whole Sharjah area. And Oman did the same, but then they took the municipality to court. We won the case, but the municipality said, yes, you can ban it, but you have to compensate the people with the money. So there were so many shops, and I think the municipality just backed off, and that was the summary of some of the things which are happening in Oman. Thank you very much.
Now it is exactly 17 minutes after the hour, and I would have loved to summarize, maybe I'd summarize quickly what has been said. Basically, the speakers have outlined the global epidemic and the spread in all the countries, whether they're running international or local surveys. Alan has also shed some light on the toxicity and some new dimension for this, which has been even further enlightened by the presentation by Mariella, which threw some additional light and emphasized the importance of these accessories in regulatory discussions. Rachel has shedded also some light about sources of funding and the challenge that this water pipe research poses to those who are interested in this field. Firas has shared with us his experience in Jordan. Tanya also highlighted things on the experience in Brazil, which is also interesting dimension, and I have a few questions for her if time allows. And finally, Dr. Lawati, in his usual interesting and stimulating character has shed the light on the experience in Oman. I would like just to open the floor for discussions, to try to gain as much possible to allow the audience here to interact with our panelists. So I'll open the floor for questions. Nadia, تفضلي. Renda. Can you use the micro, please?
Thank you all. I just have maybe comments or questions, but take it as you will. For Gemma, I think we have an issue with, I'm talking about the EMR region. We have issues for conducting surveys on tobacco and other surveys. We wait for you to tell us, go ahead and do. So I would really feel that maybe WHO should take the initiative and ask us to go ahead and make more data. The other thing which you should bear in mind now that we have barriers to do household surveys in several Arab countries, and maybe you should come up with alternatives so that we have a standard situation because of what's going on in the Arab countries and some of them. Now to Ellen, I wanted to ask Ellen, I know with all this very good information that you have, if you allow me, Chair, are policymakers aware of this information, or is it only scientific research that we are getting, but policymakers are not aware of these results? And with respect to Brazil, I'll quickly, did you do any, in your research, did you look at the ethnicity of your Brazilians so that you might target certain populations in your prevention? Thank you.
Gemma, you want to comment? Then Alan?
That's very true what you said, actually. But also at the same time, you have to remember that we've had 6 sessions of the Conference of the Parties, and it was only at this last session, the 6th session, where the topic of water pipe was even discussed. And you know how that happened? There were 2 countries from the Emerald region that really rallied the forces. They sponsored a resolution. They gave it to the COP Bureau, so it was Egypt and Yemen, who submitted it to the COP Bureau to say, please, let's include water pipe, shisha, into the agenda of COP6. And as you know, there are so many requests for agenda items. It could be 40 in a 1-week-long meeting. But it really needs, and I shouldn't be saying this because I'm WHO, it really needs the activism of the countries to make sure that it gets an issue that's important to a region or a country. It really needs some pushers to make sure that it gets into the agenda of the COP. And once it's in the agenda of the COP, then everybody is forced to face that discussion and join in and come up with this decision. So the COP came up with decisions on water pipes. And one of them is that WHO, you need to include water pipe in your survey, in your national surveys, include it in GATS, include it in GYTS and the others. So yeah, but it's an iterative process. It comes from WHO, but also the countries really need to push the decision makers.
Regarding the question about policymakers, I would say to the extent that we have policymakers in Lebanon, we have made them aware as much as possible. And I mean, of course, there's always more work that needs to be done, but this is a very good point that scientific information is communicated.
I'm not sure if I catch your question. You are asked me if in Brazil we are targeting a specific group with the campaign, in awareness campaign. No. We are just starting to put the question in the regular survey, so we cannot have a very deep profile yet on who are the person who are using. But we made the first awareness campaign in 2013, and we are very surprised with the reaction. People didn't know anything on water pipe risk, so it was very important for us to have this reaction to understand better, and now to have a more in-depth research profile on the users.
Tanya, along the same line, we know very well that Brazil has a large number of immigrants from the Middle East region. And for example, is the distribution of this population in the two districts that you mentioned, there is a somewhat a disproportionate number of these immigrants in those two governorates? Okay. Chichi.
We don't have research that could make a kind of differentiation between the migration population. We don't have this kind of,
okay.
how to say?
While I got you to comment, can you, I know Brazil had this bold decision of banning flavorings and additives, and yesterday in our discussion, it was brought up, if you ban flavorings, basically you kill water pipe smoking. Was this applied to water pipe tobacco products?
Yes, the regulation applies to all tobacco products, expressly to all tobacco products, so including nargile and other tobacco products. But we know that's not easy to inspect the compliance. Mainly if you have now the illegal market, we need to also the smuggling of nargile coming from the neighbor countries such as Paraguay. So it's easy. This is an indicator that there is interest, there is a market for nargile in Brazil, an increasing market. So we need to have much more piece of data in order to have a real picture of this situation in Brazil. So this is a very previous picture that we had the opportunity to bring today. But we are very, as policymakers, we are very concerned in Brazil with this matter.
Yes.
I have 3 questions. The first 2 questions is to Alan and Primal, which is currently there is a report from Egypt using the recycled material from hospital, from the waste of hospital, from the waste material of hospital, the plastic, to produce this pipe for water pipe. Would you expect that the exposure to toxin, the profile of toxin exposure will change, and that this will as well has its impact on the contracting of certain disease? This is my first question. My second question is to Firas. I know there is ongoing research and work on water pipe and closing some places, but still the business is ongoing. Is there any research that targeting people who's serving this water pipe as their health will be at risk, and they have to work to make their living? You know, they are just poor people and they have to make their living. So there is what we call it occupational health hazard. And my last question is to Lauren, and it's about we know there is ongoing research about the prevalence of water pipe and so on, but there is, I think, some methodological shortcoming in terms of the definition of the use of water pipe. We always use the word of current, which is loose use, and we don't know this current, is it daily, is it, for example, occasionally, and this maybe has its impact on, for example, using appropriate intervention for water pipe cessation. Thank you.
Alan, you want to give any comment?
So I'm sorry, I think what your question was, and correct me if I'm wrong, that the material that the water pipe is made of, are you asking if that has an effect on the exposures? From the waste material of hospitals? So infectious waste, you know, depending on the temperatures that the pipe is sitting around in, the water, how long it's been sitting in there, I think all of those things, you know, the aerosol that comes out of a water pipe is 99% relative humidity. So anything that's soluble in water is going to be in that aerosol. So infectious waste, I'm sure there are microorganisms that can be transferred, and One of the things that makes water pipe so harmful and allows people to take these huge puffs is because it is a high humidity aerosol, and there is a very low resistance. It's not like a cigarette where you're actually trying to pull 1 kilopascal pressure drop. With a water pipe, there's very little resistance, so it's much easier for humans to take huge, almost larger than tidal volume size puffs, liters of smoke into their lungs. I hope I answered your question. Recycled material? I think it's an important question, especially if you're using some type of plastic for the body. I think it would be something interesting and important to look into.
Hi there, good afternoon. Dr. Mohammed Jawad from Imperial College in the UK. Thank you to all the speakers for giving us fabulous insights into this important topic. I think water pipes really dominating this conference is a very important issue. My question is to Gemma, but I appreciate you may not be able to answer it, perhaps feedback to the wider teams, and maybe for any of the panelists to consider. It's about surveillance. I'm not sure if we noticed in Gemma's presentation, but the Global Adult Tobacco Survey data seems very, very low compared to all the other surveys. And we're kind of concluding that water pipe is very popular among young adults and children, and it kind of tails off among adults. I've looked really closely at the GATS survey, and I wanted to raise an important point about the way it's asked. The people eligible to answer questions on water pipe have to answer positively to the question, do you consider yourself a tobacco user? That's their first question. That's the gateway question. If they answer no to that, then they don't answer any other questions, including water pipe. And we think water pipe users, as we've seen, don't consider themselves tobacco users or smokers because of all the misconceptions. So I feel that the GATS survey may be underestimating water pipe prevalence among adults. We see, Global Youth Tobacco Survey just asks everybody about past 30-day use, 40% in Lebanon, but then 3% in Egypt on the Global Adult Tobacco Survey. So I just wanted to raise that really and hope that future surveillance questions can consider this. Thank you.
Mohammed, this point is very well taken, and I think there has been recognition that in many of these surveys, there has to be a better addressing the water pipe, and rather than just put it under other categories or even the subjects who could need to be surveyed. So there is a recognition there is a gap there that needs to be addressed in future surveys. Your point is very well taken. What I would like to, just for the remaining time, I know we're just like a couple of minutes over time, I would like just to bring the attention to the audience, the publication of the second edition of the advisory on water pipe tobacco smoking. The first edition was published shortly after the TOBREG meeting in 2005 in Brazil. And it is really I'm glad to see like a decade later we have been successful in trying to come up with a second edition. I've worked with WHO for the last 10 years, but I can tell you I've never seen the effort that has gone in getting this out in time for this meeting. So there's a lot of effort that went in bringing it to you. So there are some extra copies here up front for those of you who might be interested in having a copy of it. And in this, I'll take this opportunity to thank all those who contributed to its publication. We had outstanding group of experts who have written several sections of this monograph, reflecting on their elegant work and experience in this field. And also the WHO staff who really worked tirelessly in order to bring it to this meeting. And lastly, I would like to thank my colleagues in TOBREG for their finalization and review of this monograph and for their hard work in order to meet that deadline. So thank you for being here. You're welcome to pick up your copies. Hopefully there'll be enough for all of you. If not, This soon will be published and also will be on the website of TFI. Thank you very much.